So health promotion. Now, I always start, and you'll see I do this as well with when we do med surge in the systems. It's always important to do a quick anatomy, okay? And as we get into the physiological process, you do need to have a visual or remember the anatomy process as we get into some things. So we're gonna start with the male reproductive system, right? The only part you need to know right now for the male reproductive system, for what we're about to do for health promotion, is pay attention to the vas deferens, okay? So let me make sure you can see my cursor before I keep going, because sometimes I'm in a different mode and you're not able to see my cursor. So yes, you can. Okay, perfect. So you see my cursor moving right here on the bottom where it says vas deferens. If you follow the line, this is the vas deferens. So you do need to know where that is and what that is. You see how it attached to the testes? Because we're going to talk about vasectomy. I know the word ectomy means removal, but this is the exception to that rule, because when we say vasectomy, we're not talking about removal of the vas deferens or the testes. We're talking about cauterization. So you'll see that in a moment. So, you know, the males still have their testes. They're still producing testosterone, okay? So honestly, that is really the only anatomical landmark you need to keep in mind for right now. When we do the urinary system, we'll go over the rest. When we do TERP, we'll go over prostate, okay? Now, the female reproductive system. So with the female reproductive system, you have a front view and you have a side view, and there's a reason for that, okay? So the female reproductive system, as you see on the left side, the front view, you have 2 ovaries. Some folks have 1, some folks are born with 1, but generally most of us female have 2 ovaries, and you see the fallopian tube, okay, which leads to the uterus. Now right here, where you see my cursor going back and forth, is what we call the inner os, OS. You do need to know and remember that anatomical landmark, and you'll see why in one moment, okay? So stay tuned. Right here, right before the vagina starts, is the outer os, OS. So between the inner, right here, and the outer is what we call the cervix. Now, as we're going to get pregnant, go through a whole 9 months of pregnancy and give birth. Now the women who are like done with kids and the men who are like done are like, what? We're gonna get pregnant, have a baby? Okay, relax. Don't have a mini stroke on me here. This is just for learning purposes, okay? So those of you who are done, you're like, what? You're palpitating. Don't palpitate. All right, so we're going to talk about the cervix effacing and dilating. It's going to thin and widen, so we're going to go through all of that. So also pay attention to the fallopian tube, because when we do OB complication, we're going to talk about ectopic pregnancy, right? So now I want you to go to the right side where you have a side view of the reproductive system. Now I want you to see how the uterus, right, sits right on top of the bladder. So now imagine as the baby goes 1 month, 2 months, 3 months, 4 months, all the way to 9 months, the pressure, right, that is put on the urinary bladder. So imagine, you know, at 9 months, the woman sneezes, you imagine a little bit of urine seeping through, you know, achoo, and there's a little bit of incontinence. So keep that in mind, okay? And this is a great view too, because as you look at the uterus, you can see, you know, the inner os and the outer os beautifully as well, okay? So, perfect. So that's a quick anatomy. Now let's start with contraceptive. The prefix contra means against, right? And the root word here is seption. So against pregnancy, right? Against the eggs and the sperm meeting. So we're gonna do contraception first, and then we'll get into conception, okay? So women or couples will do this for a number of reasons. So some women are monitoring their ovulation because they want to get pregnant, and some do it because they don't want to get pregnant. So depending on what you want to do, the whole goal is to know when you're ovulating. Okay. So there are different fertility methods. So there's what we call the calendar method. The name tells you what's going to happen, right? The calendar method. So you're going to take a calendar, and most women who are regular, they will have their period, let's say on August 1st. And by August 14th, they're ovulating. So they're regular on the 14th day is when they're ovulating. So they'll know whether they want to get pregnant or not, right? And what to do. So now the next fertility method is the basal body temperature method. Doesn't the name tells you quite a bit of what's about to happen? Basal body temperature method. So this is the one where the woman gets up every morning, the same time, and take their temperature vaginally. And what happens is when they're ovulating, their temperature will spike. Okay, they'll have a dip and then a spike. So that tells them they're ovulating. Whether they want to conceive or not, then they'll know what to do. Okay, that's the basal body temperature. And they could use a regular thermometer, or they could use a specially made thermometer, right? The whole point is to see what is your core temperature and is it spiking. Now, the third method is called cervical mucus method, or the Billings method. Okay, so remember, whenever something has two names, you want to be familiar with both names because they use them interchangeably. Okay, so cervical mucus method is when the woman observes when their vaginal discharge is very stretchy. Okay, like you see in the picture here, this picture. So that's the cervical mucus method. That means you're ovulating. Okay, the environment is perfect at that point if you want to get pregnant. Now, some women do all three, right? So when somebody's doing all three, there's a new terminology, and that's the best method, right? Because you kind of catch it one way or another. And that's called the symptothermal method, right here on the bottom and on the right side. The symptothermal method is a combination of the basal body temperature with the fertile cervical mucus observation in your calendar, right? So all of it, when a woman is doing all of it, it's called symptothermal. Now, we're still on contraceptives. So there are chemical agents, or another term, spermicides, that are used to keep the sperm and the egg from joining, right? That's the whole point of contraceptive. Some contraceptive methods we're going to talk about, it causes the woman to not even make an egg, right? No egg, no baby. You're missing half the party. All right, so the point of these spermicides is to keep the sperm from joining with the eggs. They're inserted deep, they come in creams, foams, jellies, and they are used in combination with mechanical barriers. So one more time, your spermicides, whether they come in foams, creams, jellies, suppositories, whatever format, their goal is to keep the sperm and the egg from meeting, and they are used in combination with mechanical barriers that we're going to talk about in a moment, okay? So now there are contraindications for these. Not everybody can just wake up and start using these things. Okay, if you're a smoker, strike out. All right. If you have medical conditions where you've had, blood clots and, those type of conditions, bleeding conditions, those are not for you. Okay, they're contraindicated. And there's a lot of education that goes with them once we put a client on these things. We want to educate about the family planning that they want or don't want. Okay, safety measures, menopausal, impotence. So there's a lot of teaching that goes with this stuff. You don't just do it, say it, and we move on. All right, contraceptives in reference to mechanical barriers. So we're gonna use the spermicides with the mechanical barriers, whether it be a diaphragm, a cervical cap, a sponge, or male or female condoms, whichever ones. So I'll come to the hormonal stuff in a moment. Let's do the mechanical stuff first. So here are the mechanical stuff. So here's the diaphragm on the top left. Okay, you see how the diaphragm is covering the outer os that we talked about earlier. So imagine spermicide in there, plus you're covering the outer os. So not only are you making the environment unbearable for the sperm, but you're also blocking the passageway, okay? Because there's spermicide inside that diaphragm. Same thing with the sponge. The sponge is a one-time use. That's the other thing you need to keep in mind. Your diaphragm, you can rinse out, you can reuse. Never use any type of product that is oil based, always water, right? Because oil will clog the pores and cause even toxic shock syndrome, okay? So water-based. And same thing with the cervical cap. You see how all of these are hiding the outer os. So there's no passage. In addition to that, you make the environment unbearable, okay? So with diaphragms and cervical caps, you apply more spermicide. If you leave them in place for more than 4 hours, you should remove them like within 6 hours post. If you gain weight, you should be refitted for them. If you've had a history of TSS that I mentioned earlier, this is not for you. If you had an abnormal pap smear, this is not for you. If you're allergic to latex, this is not for you, right? So these are the contraindication. These women, the moment you read these questions and these histories out, this is not for them, okay? Now, let me go back. So another type of contraceptives. So far, we've talked about spermicides. We've talked about mechanical barriers. Now we're going to talk about hormonal contraceptives. The whole goal of the hormonal is to keep ovaries from releasing an egg. So no egg, no party, right? So the way it does that is going to thicken the cervical mucus and thin the uterus. That's not a good environment. Okay, so those are your birth control pills we're going to talk about. Now, your birth control pills, there's a very important concept that you have to remember. Some of them are made with one single hormone, and some of them are made with a double hormone. That's important because some hormones stop women from lactating. So if it's a woman who's postpartum and wants to breastfeed, we need to make sure she's on a hormonal contraceptive that doesn't stop lactation, okay? So we're gonna go through that right now. So Norplant, you can see Norplant is the one that is surgically inserted in the inner arm, right? You see the little coil-shaped device right here. And this works in your pituitary, where it tells your brain, okay, your posterior pituitary to not ovulate. You don't release an egg. Now, this is implanted for years. It can be removed, absolutely. But the problem is you've had it, let's say you've had it for 5 years, and you've been telling your body for all those years not to ovulate. So what you need to teach the woman is that when they take this out, and they all of a sudden want to get pregnant and have a baby, it's going to take their body a while to ovulate, like years, okay? So that's an important teaching factor, right? And you see how it's a progestin only. I'm going to show you why that's important. Right here, progestin only contraceptives does not interfere with lactation. Okay, so whenever you see a contraceptive that has both progestin and estrogen, well, really, estrogen is the one you need to keep in mind. The moment it has estrogen, they're not going to make milk, okay? If they want to breastfeed, that's not going to happen, okay? So Norplant is progestin only, okay? All right, so now we're going to talk about the Ortho-Evra. We're going to talk about the Depo-Provera. We're going to talk about the NuvaRing. So all of those stop the woman from releasing an egg, okay? So the Ortho-Evra is the patch. Let me show you a picture. So you see the patch goes in the upper buttocks or the upper shoulders, okay? That's the location of your patches. So keep that in mind. The other thing with Ortho Evra, there's a great Ortho Evra commercial. If you ever see it, pay attention. You'll see where they go. You'll see, that's the one I believe where the women are like jumping into the pool one at a time. I think, yeah, that's Ortho Evra. It's either Ortho Evra or the NuvaRing. No, it's Ortho Evra. So Ortho Evra is 3 weeks on, 1 week off. 3 weeks on, 1 week off. 3 weeks on, 1 week off. Okay, and it's double hormone. So if she wants to get pregnant, that's not the one for her. So she just gave birth. Yes, she wants to breastfeed, and she doesn't want to get pregnant, right away. So because she wants to breastfeed, the Ortho Evra is not the option. Okay, so one more time, recap. The Ortho Evra is not good if the woman wants to breastfeed, okay? And the Ortho Evra are the plastic patches that go on the upper shoulders or upper buttocks, and they are 3 weeks on, 1 week off. 3 weeks on, 1 week off. You get it. I'll come back to Depo-Provera. Let's do the vaginal ring real quick, only because there's a commonality between the Ortho Evra and the vaginal ring. So the vaginal ring, NuvaRing, is placed in the vagina monthly for 3 weeks. Let me show you. There it is right here. Okay, you see how it's going to close the outer os, right? So this is another one. It's placed in the vagina monthly for 3 weeks. So 3 weeks on, 1 week off, 3 weeks on, 1 week off type of thing. And it's double hormone. So you see how the Ortho Evra and the Depo-Provera have something in common. As a matter of fact, let me do this because this is how my brain works. I'm just going to put them right next to each other. Okay, because that tells me they have this in common. And I've been meaning to do that for some time. And I think you should do the same thing when you're studying as well, because it's good to group things together. So Ortho Evra and vaginal ring, double hormone, 3 weeks on, 1 week off. Okay, the only difference is one is a patch and one is a ring. The ring, the name tells you. Depo-Provera is different. Number one, it's a single hormone, okay? Number two, it's an injection. It's an intramuscular, okay, IM injection. With Depo-Provera, it releases in the client's bloodstream little by little by little by little for the next 3 months, okay? It is given via the Z-track method. Remember, the Z-track method is when we pull your skin back and we inject, we pull out quickly and we let go so we can seal it so that the medication doesn't seep out, okay? It's gonna cause amenorrhea without. That's the whole point. You're not gonna have a period anymore, right? And you're gonna have some irregularities and some bleeding at first. And it does not interfere with breastfeeding, with lactation, okay? So those of you who are visual learners, okay, you see where the patch go, you see Depo-Provera is an IM injection, you see the ring, okay? So in general, your oral contraceptives are going to stop you from making the egg, stop the woman from making the egg. Okay, there are some pills that contain a combination of both estrogen and progesterone. They're usually taken in the 5th through the 25th day. And if the woman misses, just tell them to take it when they remember, and then to just keep going. And also, if they miss it, they also need to find another form of contraceptive, okay, temporarily until they know that they're back on track, with their normal contraceptive. Very effective, obviously, okay? So we talked about this. The estrogen component affects the pituitary gland to inhibit ovulation. The progestin component changes the cervical mucus. So that's double whammy, right? So you're not ovulating and you're changing the environment of where a sperm would thrive. So then it doesn't. Okay, but a lot of risk. You can't just get up and get on this stuff. Okay, you just can't, because they put you at risk for blood clots. So if you have a history of, this is not for you. Okay, a lot of physicians also prescribe them to fight against ovarian and endometrial cancer. So they have other purposes other than just contraception. Okay, the mini pill, which is progestin only, it's very popular, take daily, very few side effects, very effective, great if you want to breastfeed, right? But all of these modalities, not just the mini pill, they increase your risk for ectopic pregnancy. You see why I do the anatomy at the beginning of these sessions, right? Because you need to see that. So now I give you a question where I tell you the client is on the mini pill. What would she be at risk of? Ectopic pregnancy. Okay, it slows the movement of the eggs through the uterus once they're on these medications. So keep that in mind, okay? After this section, I'm gonna check with you to make sure you're good, because we just have a couple more contraceptives. So here's another one, the IUD, intrauterine device, hence the name IUD. That's that T-shaped T-coil-shaped device that you see here. And you see how it's going to hide or block the fallopian tube, right? This is not as popular as it used to be. The Essure kind of has taken place of this, causes heavy menstrual bleeding, cramping. And here's the Essure procedure that has taken place of the IUD, because this is now more popular. Okay, you see how it also uses a coil tube or mesh to block the fallopian tube. Now this is done transvaginally. Okay, it's inserted in the fallopian tube to block it, so it kind of makes a wound, and then your body heals and closes that pathway. Okay, see, elicits tissue overgrowth, so it causes like a scar, and it blocks the pathway. Very effective, 99% effective, and no side effects, which is great. We like words like that, right? Here's the last one, your emergency contraceptive, or AKA morning after, or AKA plan A didn't work. So you need a plan B. Is progestin only. The whole point with this one is take it as soon as possible. 3 days is actually a long time, folks. 3 days, my goodness, we could march, to another county in that time. So common side effects, nausea, vomiting, dizziness, breast tenderness. But with the plan B, the sooner you take it, the better, okay? All right, now these next two contraceptives are permanent, okay? In real life, you can undo them, but for NCLEX purposes, think of them as permanent, okay? So we're gonna do the male first, and then we'll do the female, okay? So with the male permanent sterilization, that is called a vasectomy. So earlier I showed you the anatomy of the vas deferens. So this is like a front view of this. So you see how we're not removing, even though the word ectomy is there, we are cauterizing or tying, right? So it's a closure. There are a few NCLEX questions from this area, so listen up, okay? So with the male, permanent sterilization, vasectomy does not cause immediate sterilization. That means the male can impregnate a female for up to 6 weeks. So NCLEX, they need to make sure their ejaculates are free, from the sperm, one, or they could wait well after 6 weeks, right? In the meantime, teach them to use another form of contraceptive, right? But NCLEX, the male is not, okay? I need to bold that, highlight that, and capitalize it. Not immediately sterile, okay? That's how important that is. And that question is not gonna go anywhere. It's just always gonna be there. And it's opposite for the women. The other thing you need to remember for male, it's local anesthesia, okay? And same day, outpatient, like not a big deal, okay? But for the women, it is a bigger deal. It is under general anesthesia, and the women are immediately sterile. You see how opposite these are? And here's another thing for the female. It is mandatory. There is a mandatory 30-day waiting period from the time the consent is signed until the day of surgery. So if you plan, let's say you sign the consent today, you have to wait 30 days or after for the surgery to take place, and that is mandated, okay? So there's different terms for this, whether you say, you know, bending it, cauterizing it, tying it, tubal ligation, tubal sterilization, all of it is the same. But for the female, general anesthesia, longer recovery time, mandated 30-day wait period. Okay. All right. So we'll practice a question, and then I'm going to take some questions from you. A client who had a vasectomy is in the post-recovery unit at an outpatient clinic. Which of these points is most important to be reinforced by the nurse? So try this question. Let me fix this a little bit. First of all, let's unbold that. The only word here that should be bolded is the word most. Okay. And let's see if we can make this a little bit cleaner. All right. So I hope you were reading the answers while I mess with this a little bit. So a client had a vasectomy. What is the most important reinforcement? Okay. Is it most important to now you see the word most, so you know some things here are important, but one of them take priority over everything else. Okay. Nobody has a vasectomy to get pregnant, right? Folks do these things because they're done. The ship sunk like the Titanic. It's over, right? So is it A, until the healthcare provider has determined? Actually, yeah, throw me some answers before I give you. Okay, yeah, some of you are so quick. Awesome. Yeah, it is A. Until the healthcare provider has determined that your ejaculate doesn't contain sperm, you need another form of contraceptive. Absolutely. Now, if you, like some people like literally don't know that they need to wait 6 weeks, right? They just don't unless somebody tells them. So imagine you didn't tell them. Oh my. All right. So priority. Yeah. Let's make sure. All right. So now abortions is another topic, right? So let's say the person absolutely did not want to get pregnant. So you know there's elective abortions, and then there's spontaneous, right? Elective, you chose to do it. Spontaneous, nothing of your doing, but yet there's a loss, right? Of the fetus. So the whole thing with abortions, we're going to talk about abortions when we do OB complication as well. However, you need to keep in mind or pay attention rather, what trimester is she in? Because depending on the trimester will tell you whether you're doing a dilation and curettage or a dilation and evacuation. Are you doing a DNC or are you going to do a DNE? DNCs are done first trimester and DNEs are done second trimester. Okay. So whether the physician is going to use cytotac, okay, misoprostol, okay, or mifepristone, but once they're 8 weeks or less, it's going to be a DNC. Now, post, your first trimester, it's a much bigger fetus. So it does require evacuation, maybe even saline injection, and prostaglandins. And you see the picture on the top right hand. So, all right. Any questions so far? We're going into a different topic now. We're going to talk about some teaching prior to pregnancy. And then we're going to get pregnant and get into the different trimesters of pregnancy. So does anyone have any questions so far? We're moving beautifully. I'm looking at the time. We're doing fine. We're doing great. And as you can see, this was not heavy material, but you could see how there could be some select or lot applies from this material, especially with the contraceptives. Okay. But again, not heavy stuff. So any questions? I'll keep checking to make sure. Okay. Balanced diet. So balanced diet, we're teaching the woman that she should be on folic acid even prior to getting pregnant. So everybody who's at age of being pregnant should be on folic acid, okay? Critical prior to pregnancy and during your first trimester, especially during your first trimester. Don't forget that component, okay? The first trimester is critical for those nice, beautiful red blood cells. We decrease neurotube defects, right? We don't want children with spinal bifida, with the spine not closed completely. And that's what folic acid helps prevent. Now, pay attention to words like guarantee. There's no guarantee, right? So I've seen questions like that where it tells you, you know, the nurse tells the mother to take the folic because it doesn't guarantee, but it does decrease the risk of. Those are more the words you want to see, right? All right. So if they're at childbearing age, you know, take it. Now it's recommended 600 micrograms. If they're anemic, it's 1 milligram. That's recommended every day, okay? So now there are some risk factors. And the risk factors for pregnancy are the young and the old, okay? And in pregnancy world, we don't mean young, you know, as in like your early 20s, we're talking 16, 17. And we don't mean old as in a geriatric, right? We mean old like 35. In pregnancy days or world, 35 is old. Okay, so when we say old here, under this setting, under this umbrella, we're not talking about geriatrics. Okay, we're talking about 35-year-olds or older, which are like, that's not old. No, it's not. But under this umbrella, it is. So if you're over 35, because your eggs age, that's why. So some risk factors. If you're 17 years, pre-eclampsia, preterm labor, anemia. But the 35-year-olds are more at risk of the hypertension, the gestational diabetes, preeclampsia as well. Placenta abruptia, placenta previa, which we'll talk about later, chromosome, Down syndrome, right? So you want to educate, malnutrition, and then this one is important, previous pregnancy complication. Whoever, you know, had any of these complications in previous pregnancies are at highest risk, right? You know, there's risk questions. So whoever, your history puts you at risk. And it's not just in pregnancy, it's in everything. Like a client who's most at risk to fall is the one who fell in the past. A client who's most at risk of an ectopic pregnancy is the one who had an ectopic pregnancy. A client who's most at risk for a stroke is the one who had a stroke. So your history, okay? So we also want to find out, you know, any previous disorders, infections, medications, drug, alcohol abuse, smoking, all of those puts you at risk, especially smoking. You know, no drinking or smoking because these things cross the placenta. And we're going to talk about toxoplasmosis. So there's a lot of risk factors and things we need to teach the woman, right? We just talked about the folic acid. Tell them increase your diet. We want you to be gaining some weight, right? So increase your calorie intake at least 300 extras per day, more if you're pregnant with twins. So we're going to teach them about avoiding teratogenic substances. For example, moving forward, you only eat cooked, well done meat, right? You don't want to eat rare, like bloody, right? And let's talk about the toxoplasmosis. So toxoplasmosis crosses the placenta. So the mother needs to be taught if she has a cat, she can no longer be the one to be changing the cat litter. Somebody else needs to do that. Okay, there's a little mnemonic for you called TORCH to help you remember toxoplasmosis, syphilis, rubella, CMV, HSV, all affect the baby. So we want to teach her about that, okay? So no more changing the cat litter, especially if you have animals that are indoor, outdoor, right? Because they eat dead animals and it's in their feces. So also let's take this to somebody who lives in a farm, right? You cannot handle animal manure anymore, okay? Because these things are in there. Folks who garden, right? Some people love gardening. Yeah, no more gardening for you if you're pregnant because it's in the dirt. So it's stuff like that you have to teach them, right? No more over the counter, no more x-rays, no more saunas, no more hot tubs. The only vaccines we give while you're pregnant is the flu and the ROGAM if you're a candidate. And we're going to talk about the ROGAM in a moment, right? The flu and the ROGAM. We're not giving anything live. We're not giving any measles, mumps, rubellas, right? So these are the things you need to remember. And for the x-ray, we don't want that exposure to radiation, right? Even though it's a small exposure, it's still too much, okay? All right, so some lab tests we're going to pull. All right, we're going to get some urine, right? We want to check it for glucose, for protein, for blood, for bacteria. We're going to pull the HCG level. We can tell how many days pregnant she is just from her HCG level. We're going to do a CBC. We're going to do a rubella titer. We're going to screen for some sexually transmitted infection, especially if they're at risk, right? But that depends on the individual. So if it's somebody who comes into your clinic and they don't know who the father of the baby is, then yeah, that tells you probably need to pull some STIs, get consent for the HIV test, right? We're gonna pull the hepatitis B. We're gonna do spot smear, tuberculosis test, but that depends on their risk factors, right? So there are some lab tests you're going to pull. Don't forget the HIV, you need a separate consent for, okay? The general consent does not work, okay? You're going to teach her about Kegeling because that helps strengthen the pelvic muscle for birthing. Okay, and it just helps you prevent you from having incontinence when you're old. So whether you're pregnant or not, you should Kegel, okay? And you can do it while you're urinating, okay? All right, conception now. So we're going to allow the egg and the sperm to meet, right? Let's say you want to get pregnant, so hence the word conception. So that's when the ovum penetrates the sperm. Yep, there's a meeting. And then fertilization is going to take place, right? And then implantation. So that's when they take a little trip and implant right in that uterus that I showed you earlier, which is where we want it. We don't want it in the fallopian tube. We don't want it too low, close to the inner os. We want it right at that, edge of the uterus, okay? So here's your meeting, all right? Here's your little trip going back for implantation, okay? Now, there are some terminologies that you need to be familiar with, right? Because I could use the term, just from the term that I use, you need to know how many weeks pregnant this woman is, all right? There's a lot of vocabulary words here because this is a new language. So we're getting into that. Vocabulary word zygote. So if I say, this is at the zygote stage, the woman is less than 2 weeks pregnant. Once I use the word embryo, she's between 2 and 8 weeks pregnant. Once I use the word fetus, she's 9 weeks plus pregnant. One more time. Zygote, less than 2 weeks. Embryo, 2 to 8 weeks. Fetus, 9+ weeks. Okay? So I don't need to tell you how many weeks if I say she's in the embryonic stage, right? It's a fetus. This is where there's a lot of controversy, where people are like, well, it's not a baby until it's an embryo. It's not a baby until it's a fetus. Don't get into that mess. That's not NCLEX stuff, okay? You just learned the vocabulary words. Leave that other stuff for the politicians. All right. The placenta itself has to be nourished, right? As it nourishes the child. It's going to produce a lot of hormones. We just talked about progesterone and estrogen. So in addition to that, it's producing the HCG, the human chorionic gonadotropin hormone. It's producing HPL, the human placental lactogen, okay, in order to keep this baby. Isn't that amazing? That's just all amazing stuff. That is so cool. All right. More vocabulary words, okay? I'm sorry about that. I did tell you that this is a new language, okay? But let me chime in with you and make sure you're good. Is everybody good? Send me some thumbs up. Yes, I'm learning. Keep going. I'm not going too fast, so nobody say I'm going too fast. Oh. So let me pause for the cause and make sure you're okay. Okay. All right, let me check with you. Okay, is everybody okay? I have some yeses coming. All right, awesome. So everybody's good. So let's resume. I want to make sure I can see you on this screen, but it's so tiny. All right. So now more vocabulary words, okay? Hold on. Where's my PowerPoint? There we go. Okay. More vocabulary words. Let's do this. It's a new language, okay? This is a new language. That is just, the way it is. It's a new language. Not so much I can do about that. Parturition. So when we say parturition, we're talking about the birth, okay? The birth process. That's a root word, and that's really all it means. The part of it, partum, refers to a time period, okay? So when we take that root word, partum, and we put a prefix in front of it, we change it, right? So if I say antepartum, I'm talking before the birth. If I'm saying intra, during the birth. Postpartum, after the birth, okay? Why is that important? That's important because once I use that term, there's different things happening. Your nursing intervention is different, okay? So if I tell you, the woman is in the antepartum phase, this is where, she's effacing, dilating, her mucous membrane might have come out type of thing. I'm monitoring both mom and baby. Intrapartum, the birth is happening, right? There's a whole process of how the baby comes out. We're going to talk about that. Postpartum, that's recovery stage. We take out the placenta, mom is recovering, there's risk of orthostatic hypotension. So you have to see where in this process are you, okay? And imagine what's happening and what's priority, what's important, okay? So now we have to get into a little bit more vocabulary words and meaning as well. And there's NCLEX questions here. So you want to make sure you get a very good understanding. And I'm going to throw a couple of questions at you just to see if you understand, okay? Because remember, that's my part. And then your part is to reinforce it, okay? And the sooner you reinforce it, the better. So gravida. Gravida means the number of pregnancies. How many times has this woman been pregnant? Now, it does not matter how many babies are in there, okay? Whether you're pregnant with one baby or 5 babies, it's one pregnancy. Parity is the number of times the woman has delivered. Whether they've delivered 1 baby or 5 babies, it's one delivery. Nulli, you've never been pregnant. Preemie is your first pregnancy, preemie gravida. Multi is more than 1 pregnancy. And there's grand multis, those who have 4, 5, 6, babies. So those would be prefixes, right? Now, parity, the number of deliveries is broken down further into what we call TPAL, right? So the woman delivered, yes, but was it a term baby? T. Was it a preterm baby? P. Was it an abortion less than 20 weeks? Was it a living? Okay, is the baby fine at home? Not a problem. So you need to break TPAL, or you need to break parity, right? So sometimes you'll see the 5 point, they're talking about the GTPAL. Okay, so what is the GTPAL? What is the gravity and parity? Okay, so don't forget your trimesters. Week 1 through 12, trimester 1, 13 to 28, second trimester, 28 till birth, third trimester. Okay, so terminology again. All right, so let's practice a couple of questions. A woman comes to the antepartum clinic for a routine prenatal examination. She is 12 weeks pregnant with her second child. Which of the following shows proper documentation of the client's obstetric history by the nurse? So she comes to the antepartum clinic for a routine prenatal exam. She's 12 weeks pregnant, gravida 1, with her second child, gravida 2. So there's only one here that says gravida 2. There's no such thing as newly gravida 2. That means you've never been pregnant 2. No. Absolutely. Gravida 2 and power 1 because she's still pregnant with that one baby. She has not given birth to that one pregnant baby, right? Awesome. Let's try this one. The nurse cares for a client who delivered an infant at 30 weeks gestation. The client has one child at home who was delivered at 41 weeks. She has had 2 abortions, 1 spontaneous at 7 weeks, and 1 induced at 9 weeks gestation. Using the 5-digit system, the GT-PAL, the nurse records the client's gravida and parity as. So you see how the other one was a much easier. Now I complicated a little bit. Okay, so typical NCLEX question. So you need to write down GTPAL and figure this out. So let's figure out the gravida first, okay? So the nurse comes to the clinic who delivered an infant, so that's gravida 1. They have one child at home, gravida 2, who was delivered at 41 weeks. She has had 2 abortions, that's 2 pregnancies, right? 2 abortions, so that's gravida 4. 1 spontaneous, 1 induced. So we know G is 4. So you can get rid of 2 and you can get rid of 3, right? Yep. You see how simple, like we just knocked out 2 of these? Term. The term baby was the 41-week one. So we know the T is 1. Preterm, she has had 2 abortions, 1 spontaneous, 1 at 7 weeks, and 1 induced at 9 weeks gestation. So preterm is 1. Abortion, she has had 2 abortions. A is 2, and L is 2, so it's 4. Awesome. So you see how we could take this and make it easy. And we could take this where you need pen and paper. Okay, so you have to practice. Okay, that's all I can tell you. You have to practice. But once you get it, like my job is to do the teaching. So now if we complicate it some more and make her pregnant with twins, it doesn't matter. It's still gravida 4, right? The only numbers that are going to change with the twins would be the L. Okay, am I making sense, everybody? So don't get these questions wrong. They're not considered to be, super difficult questions. It's just a matter of you knowing what we just did. Nigel's rule is on your NCLEX as well. So they'll give you a scenario and ask you for the date of delivery, okay, for this child, estimated date of their date, birthday, right? And you gotta figure it out. So with Nigel's rule, with the first day of the last normal period, the first day, not the last day, the first day. So you're going to outline the date of the menstrual cycle and put it the way we normally put dates, right? We normally put month, day, and year. That's how we do. Like if I were to write, the date, we can do this example, you can do another example. So the woman had her first day of her last menstrual cycle was June 1st, 2019. So 6, the month, 1 in the year, 19. So Nigel's rule says -3 from the month, so -3, +7 to the day, +7, +1 to the year, +1, and then do the math, right? So if I -3 from 6, that's 3. If I add 7 to 1, that's 8. If I add 1 to 19, that's 20. So this baby's birthday is March 8, 2020. Okay? So step 1, put the date of the first day of the last menstrual cycle, month, day, year. -3 plus 7 plus 1 to get the child's date of birth. All right, everybody's good? Everybody's good with GT-PAL, okay? And everybody's good with Nigel's rule. If not, let me know, because we're going into a different topic. It's not time for a break yet. All right, signs of pregnancy. This is an important topic. I've had several students share with me that they've had these questions on the test. So there's signs that you're pregnant, and some of them are considered to be presumptive or possibly you're pregnant. Some of them are considered to be probably you're pregnant, and some are considered to be positively you're pregnant. Okay, so presumptive or possibly you're pregnant, the woman comes in and says, I don't have my period, I missed my period, amenorrhea, I'm tired, I'm nauseous, all of that, right? That's all subjective data. Probable cause of pregnancy is you observing, right? You doing an assessment where you're looking at the cervix, you're looking at the uterus, you look, right? So those would be the Chadwick, Hagar's, and Goodell sign. So you do need to be familiar with these three, okay? Let me highlight them. Let's bold that, Chadwick. Let's bold Hagar, and let's bold Goodell. So now, here's a little thing you need to see. So Chadwick increases vaginal vascularity, contributes to bluish purplish hue of the cervix, vagina, and vulva. Whereas the Hagar's increases vascular softening of the uterus. Okay, so, and Goodell's cervical softening caused by stimulation from estrogen progestin, but it works on the cervical. And this one is vaginal, which really includes all three. Okay, so hopefully that helps you differentiate the three. Okay, but those are observed, they're objective. Okay, whereas presumptive possible is a combination, and positive, you see a baby, right? You're doing ultrasound. Yeah, with practice, and the sooner you practice questions, the better. Okay, I mean, absolutely. Here's a nice question. So you see how we just learned the material, but once you practice question, we can put it all together. The nurse assesses a client during the client's first prenatal visit. The nurse determines that the client is 6 weeks gestation. The nurse identifies which of the following as a probable. So let's go back. So we did presumptive or possible, and then probable, and positive is you seeing a baby. Okay, look at under probable here. Positive pregnancy test, enlarged abdomen, Hagar's, Chadwick, Goodell's, allotment, probable fetal, So this little mnemonic really helps. Okay, you see presumptive, these are all stuff folks come in and say to you. Okay, so here they're questioning you about what is a probable sign of pregnancy. Okay, amenorrhea is a possible. So between amenorrhea, positive urine pregnancy test, urinary frequency, which would just be an UTI on that one, fetal tone auscultation, that would be a positive sign. So yes, 2. Some of you are throwing answers at me. Absolutely. Probable sign are observed by the examiner. You do a pregnancy test, right? The uterus is enlarged. You have the Goodell, Chadwick's, and all that good stuff. The others are not. Presumptive is what they're saying. This is a UTI, and an ultrasound would be a positive sign. Okay? So you see how we learn the material and then you practice questions. It reinforces it. So the next time you see this question, no matter what angle, so now let's say I change this to say positive, the answer would be 4. Let's say I change it to say possible, you know it's going to be A. Okay, so I could even change it to say signs of urinary tract infection. It's going to be the urinary frequency. So it's good to understand instead of memorizing. And I think that's what a lot of students do while they're in nursing school, is they focus on memorizing question and answer. And then when you don't see it the way you memorize it, it kind of throws you off. So it's better to understand. So no matter how I phrase it and flip it around, you'll be fine. Okay. So diagnostic tests. So this is another idea. With the diagnostic test, there's different kinds, and some of them have windows, right? Some of them have windows, so that tells you there's a certain number of weeks or during a certain period of time during the pregnancy that they're best to be done, okay? So some of them, they're just not effective before or after that window, or it's even dangerous to do it before or after that window. So keep that in mind, okay? So there are some diagnostic tests we do first trimester, some we do second trimester, and some we do third. The only one that's the exception to this rule is the basic ultrasound, okay? So the basic ultrasound, all we need now is a full bladder, okay? Now that's still NCLEX. Now I know, you know, there's like all these new technology out there where you don't even need a full bladder anymore. In some tests, you may not need a full bladder depending on what you're getting done. But for NCLEX purposes, the basic ultrasound does still require a full bladder, okay? And that can be done throughout the pregnancy, okay? We do start it first trimester though. All right, let's talk about the CVS. Let's go through each of these diagnostic tests. So the amniocentesis in the CVS, so you see here how the CVS is done first trimester. The amniocentesis is done second trimester with the quad marker, which is just blood work. And then the rest of them are done third trimester. We're gonna talk about the kick count, the non-stress test, the biophysical profile, the umbilical sampling, this one we're gonna spend a moment with, contraction stress test, okay? So let's go through them. The amniocentesis and the CVS, the chorionic villus sampling, I put them together not because they're done around the same time, but because they both have the same risk factors. So amniocentesis, we're getting a sampling of the amniotic fluid, right? The chorionic villi sampling, we're getting a sampling of the villus that's inside the uterine wall, right? So both of them must be done under the guidance of an ultrasound because you could poke the baby, right? Both of them put you at risk for infection. Both of them put you at risk of leaking amniotic fluid. So they're similar, right? And they're risk factors. So that's why I put them together, but they're not done during the same time. The amniocentesis is done second trimester, okay? Your CVS is done first trimester. Okay, so the quad marker, again, is just blood work, no special prep or anything like that. The biophysical profile, that one is a little complex because it looks at a lot of things with the child. So it looks like the fetal breathing, it looks like the fetal movement, it looks like the tone of the child, the reactive fetal heart rate of the child, amniotic fluid that the child is floating in. You see how this one is a little bit more, you know, in depth. The blood sampling, also some risk factors with the blood sampling. Now this one, we're definitely looking for chromosome abnormalities, and this is voluntary. Nobody has to do a cord sampling because you see here, this is a needle. How invasive is that, right? Risk for infection with that. So, but just know it's done, but it's optional. All right, so new topic. And I do need you to wake up here because ROGAM is a little complex. I need you to wrap your brain around it, and I will go slow. I will repeat myself. We will practice questions, right? Because by the time we're done, I want to make sure you never get these questions incorrect, okay? But it is a little bit of a complicated concept, okay? So, ROGAM. So you know, as Mrs. Jones come into your clinic, you're gonna type and screen her. We need to know what her blood type is, right? Is she A? Is she B? Is she AB? Is she O? And then on top of it, is she positive or negative, right? What is that RH factor, okay? rhesus factor. Now, so we test all pregnant women, okay, for their blood type and their Rh factor, along with antibody screening first visit, okay? Now, we could do this a couple of different ways, okay? When we're doing this on the mother, which is the most common way, it's called an indirect Coombs test, okay? When we do this on the newborn neonatal cord, it's called a direct Coombs test, okay? Direct versus indirect. Direct is the baby, indirect is the mother. One more time. Direct is the baby, indirect is the mother. Don't forget that. You'll see why in one moment. Now, once we do this blood work, are we looking for positive, negative, which is good, which is bad? Like, what's going on here? So here, a normal, negative, indirect, so that's the mother, Coombs test tells us that there are no antibodies detected. Antibodies are your defense mechanism against pathogens, against bad guys. So the antibodies are the good guys. They fight for us. They're our army, right? So that means there's no clumping, okay? So that's a normal negative. That's actually the good one, folks. Okay, normal negative. It is normal to be negative. The thing is, it's priority to keep the woman that way. So the indirect Coombs test says there's no antibodies, no clumping, no fighting. The armies were not activated. It did not think there was a pathogen to attack. Okay, so the thing is, NCLEX, you want to keep her that way. It is extremely important to keep the woman negative. So the way we keep her negative is with the RhoGAM. So negative women are candidate for RhoGAM, but they are only candidate for RhoGAM if they are pregnant with a positive baby. Okay, now the opposite end of that is an abnormal positive. So abnormal positive of an indirect, the mother, Coombs test means that there are antibodies. There is no need for RhoGAM, because when you see antibodies, that means that her body already knows of the positive antigen. It's not going to attack. It doesn't see it as the enemy, okay? So there's no need for the RhoGAM. She will not attack the baby, okay? So no need for RhoGAM with an abnormal positive indirect Coombs test, which shows that there are antibodies, okay? What RhoGAM is going to do, it's going to suppress the immune response of the non-sensitized Rh negative mother who was exposed to Rh positive antigen. Okay, this gets a little bit more complicated, so hang in there. Now, you have a negative mother, Rh negative mother, who meets an Rh positive father, and she gets pregnant. So the Rh negative mother now is pregnant with an Rh positive baby. The cells from the Rh positive baby, okay, enters the woman's bloodstream, either via the amniocentesis, abortion, ectopic pregnancy, the birthing process, you go on and on. So now the woman becomes sensitized, okay? So the antibodies from the positive baby cause that. So the problem is going to happen in the next pregnancy. So the next time she's pregnant with an Rh positive baby, her body will attack that baby unless we give her RhoGAM. Now, when she, the mother, attacks the baby, there is a terminology for that called erythroblastosis fetalis. It sounds like a video game, right? Mortal Kombat. I have kids, and I used to love playing video games. So it does sound that way. Erythroblastosis fetalis. That's when the mother attacks the baby. The baby does not attack the mother. One more time. The mother attacks the baby. The baby does not attack the mother. Very preventable with RhoGAM. Okay? So this is another chart of the same thing. Okay? Because I got issues. So here's another chart of that. So this is all the mother, Rh factor, the father, Rh factor, the babies, Rh factor, and nursing prevention, okay, or precaution. So if everybody's positive, there's no intervention that needs to take place. The mother will not attack. She's positive. If everybody's negative, also no nursing intervention. Okay, because they all recognize each other, right? The mother will not attack a negative. Now, if the mother's positive, the father's negative, the baby could be either or, but there will never be an attack either because the mother is positive. Now, the only time you need ROGAM is when the mother is negative and the baby is positive. That is the only scenario you need ROGAM. One more time. The only scenario you need ROGAM is when the mother is negative and the baby is positive. Okay? That is the only time. So ROGAM, okay, is going to prevent the development of maternal antibodies. It's going to keep her negative. Okay? So risk. Rh antigen from the Rh positive baby leaks into the placenta and causes this problem. So the first baby causes the problem, whether it was an ectopic pregnancy, an abortion, a birthing of the baby. And it's only a tiny little bit of blood that needs to cause this. It doesn't need to be a whole heap of blood, right? Treatment. ROGAM twice. Treatment. ROGAM twice. When? During pregnancy. Remember earlier I told you you're giving the flu vaccine and ROGAM, nothing else, right? So you're going to give during pregnancy 28 to 30 weeks and postpartum, right? Within 72 hours postpartum. So anytime you have a negative mother and a positive baby, there's some type of exposure, right? Possible exposure. Whether it was an ectopic pregnancy, miscarriage, abortion, amniocentesis, whatever. There's an exposure. You see 0.1 ml. You're going to give it during pregnancy, second trimester, and within 72 hours postpartum. All right, let's practice some questions. Woo, are you ready? Let's see if you get it. And I'm not going to help. Preemie gravida with blood type A negative is at 28 weeks gestation. Today, her physician has ordered a ROGAM injection. Which statement by the client demonstrates that more teaching is needed? If you miss this word, then you're doomed, right? Because that tells you test-taking strategies, right? That tells you you're looking for an incorrect statement. So she's saying something here that is abnormal, that is wrong, that is incorrect. Tell me. Nice question, huh? Some of you are like, Uh-oh, throw some answers at me. Let me see. Okay, I see with a question mark, but yes, you're right. Okay, I'm getting this shot so that my baby. No, it is not the baby that develops antibodies. It's the mother. The others are correct. Okay, I understand that if my first babies are positive, I'll be getting another one of these shots. Yes, you will. This shot will prevent me from becoming sensitive. That's what it does. This shot should help to protect me from future. Yes, it does. Okay, so yes, A is the problem. The baby does not develop antibodies, the mother does. Awesome. You can go over the rationales in detail later. For which of the following mother-baby pairs should the nurse review the Coombs test in preparation to administer RhoGAM within 72 hours? What is the only scenario where we give RhoGAM? Yes, RH negative mom and RH positive baby. That's it. This is just a chart in a multiple choice format. That's all. All right, so now we are going to go through the stages of pregnancy. It's not time for a break yet. So first trimester. So each trimester, there are some things that are happening with the woman. There are some specific tests that we want to do, some specific assessments that we want to do. This is not a heavy section either, especially for the women. Men, there might be quite a few things you need to learn, but women who have gone through pregnancy and birthing process, this should be like a breeze. So the first trimester, the first 12 weeks, you know, there's some nausea and vomiting. We're going to get the history and physical. We're going to find out the risk factors, like, do you have a cat, right? We're going to get some baseline vitals. We're going to do a physical assessment, looking for those Chadwicks and Goodalls, right, that we just talked about. There's going to be a lot of lab work, especially the older she is, the more blood work we'll need to do. But we're going to pull the HCG. We're going to check out the RH factors, CBC, rubella, hepatitis. We talked about the HIV, needing an extra consent. So this is all repetition, right? I've already said most of this already, which is great. We like repetition. And she's going to tell you, you know, some things about her morning sickness, breast hurting, right? Urinary frequency, all of that good stuff. So that's all first trimester. But what's happening in utero? What is this child doing? We talked about the terminologies with embryo, right? Embryonic period and stuff like that. So all of that, again, is repetition. But there's a couple of things I'm going to pull out from here. So number one, when can we tell whether we're having a boy or a girl? Week 12 is the earliest, right? According to the book. Now, I know these ultrasounds and everything, you can, but let's go by the book, right? I teach by the book. So by 12 weeks or week 12, you can tell whether you're having a boy or a girl, okay? And thank God NCLEX doesn't go into, you know, when does the child eyelashes come out, right? When the, thank God, because it's like, who cares about these details, right? So don't spend too much time on that stuff, you know, with when the outer parts and all of that. But the sex differentiation, the surfactants, that type of stuff we're going to pull out. Those are important to know when that's happening in utero. But don't go into too much detail when the child's, you know, legs, arms, feet. No, please don't waste your time with that stuff. All right, so we went over the terminology. Now, second trimester. Second trimester, there's going to be some different tests you're going to start to do. This is a bigger, right? Bigger fetus. So you're going to start doing the Leopard's maneuver. We're going to talk about the fundal height. So with the fundal height, and this is also another section where depending on your OBG, they may not do these tests anymore, but for NCLEX purposes, we're going to go over them. So the Leopard's maneuver is you feeling to see how is this baby in utero. Are they upside down, butt first, feet first, all of that. Fundal height uses a ruler, a centimeter ruler, right? So you start the centimeter or the measurement from the symphysis pubis until you feel the baby stops, right? So in however many centimeters you get is however many weeks pregnant the woman is. Again, some physicians are not using those anymore, but for NCLEX purposes, that's what fundal height is. I'm going to show you some pictures of Leopard's maneuver, okay? We're doing the quad screen because we're second trimester. We're doing a diabetic screening, which we're going to talk about. because we're second trimester. So this is where she may have some mask of pregnancy, which is called melasma. Okay, melasma. Some women, it's different for every woman, right? This is individualized. Some women get very dark, some their nose grow, like different stuff for different women. They may get the linea nigra, the black line, leg cramping, bleeding gums, H&H will increase. So that's all second trimester stuff, okay? So here's leopard. So there's a couple leopard questions on the real NCLEX, so you need to know what's happening with this. So you're gonna palpate the fundus to determine which part of the baby is in the fundus, right? So after that, you're gonna palpate each side. So here's picture number 1 on the left. You're palpating the fundus. Is it a buttocks, a head, arms, legs? Like, what am I feeling? And then you're gonna palpate the side, like in picture number 2 here, okay? And then in picture number 3, you're at the symphysis pubis. What's there? Is it a head, a foot, fingers, toes? What are you feeling? Okay, while you're applying pressure on the fundus with one hand, your index fingers and thumbs of the other hand are palpating the presenting part to confirm how this baby is. Okay, so that's the Leopard maneuver. Air to Air did a great job in showing that. Okay, so first the fundus side to side, then the symphysis pubis. All right, so you're good with that. Another picture. So those of you, you know, I like to show you the visual. Now, a couple of things I want to pull from here. There's an important concept that's happening here in utero at week 24. Okay, so week 12 was the sex differentiation. Double that. Week 24 is an important milestone for this baby in utero. Why? Because they are starting to make surfactant. Why is surfactant important? Why do we care? Surfactant is important because that is the substance that is in the alveoli of every person. The more surfactant you have, the better you're able to breathe on your own. So the baby in utero at week 24 begin to produce surfactant. That's why they're more able to survive post 24 weeks because what surfactant does, it allows the alveoli to stay open to blow off CO2, right? They breathe in O2 and they blow off CO2. And the surfactant allows their alveoli to stay open to do that. So when they come out, the more mature they are, the more surfactant they have. They don't have to be on a ventilator. That's why week 24 is important, okay? So that's why when somebody's going into preterm labor, we want them to stay in utero as long as possible because the longer the baby stays in utero, the more surfactant they make. Don't forget that. We cover surfactant again in respiratory system, but it's so important right here. Okay, by week 28, 4 weeks later, a month later, respiratory system can support gas exchange. So if this baby's born at that point, yeah, they may be in ICU for a little while, but they can breathe on their own. Okay, more chances of them surviving. Okay, so keep that in mind. Now, 2 more concepts I want you to remember around this time. So the more premature a child is, the more lanugo that they're gonna have. Lanugo is that the little hair, you know, they have all this little hair on them the more premature they are. But the more full term they are, the more vernix. Vernix is a cheesy substance under their neck, under their arm, with the boys in their scrotum. Okay, it's good to remember that. So I tell you the child's born, you know, with a lot of lanugo, you can assume they're preterm, okay? So in second trimester, they have a lot of that because they're preterm, right? But the more full term the baby is, I'm gonna show you vernix, the more vernix they have, okay? So keep those 2 vocabulary words in mind, lanugo versus vernix. One more time, the more full term, the more vernix. The more preterm, the more lanugo, and vice versa. A preterm baby is not going to have any vernix, right? And a full-term baby is not going to have any lanugo or very little, right? So keep that in mind, okay? Vernex versus Lanuvo. About 6 months is when they say the baby can hear the outside world. So that's when we say, you know, talk to them, play Mozart music and all that stupidity, right? Not really. But there's a lot of evidence that show that they can hear the outside world. But supposedly research says that, you know, if you play Mozart music to your child, they're more intelligent. So don't we all wish our parents played more Mozart music? That's funny. All right, 3rd trimester. So now lordosis is happening, right? So pedal edema, pregnancy-induced hypertension, deep tendon reflexes, insomnia, shortness of breath, Braxton Hicks, constipation. Oh my goodness, pregnancy sounds so much fun. I have a friend who found that she's pregnant and I swear she's so miserable, poor thing. And it's so funny, my other friend and I are laughing at her, and because I tell her, I said, just the thought of being pregnant again would kill me. Like, forget the actual pregnancy, just the thought. All this mess is not fun, okay? Poor thing, like we were in Bible study and she was just ready to pass out, like all nauseous. And I'm like, okay, let's end this meeting so you can just go lay down. I do not, like, I'll live vicariously to other women. Ugh. I remember telling the OBGYN, I'm like, take it out, burn it, crush it, rub it, running over with a car, like I'm done. So I know how some of you were having palpitations when we said we're gonna get pregnant. It's like, yeah, no. No, this is all horrible to me. Like the heartburn was terrible. Ugh. Anyway, focus. NCLEX. So 3rd trimester, lungs are fully formed. Yay! So this is great because they won't need to be, you know, on a ventilator, which is awesome. So 36 weeks, Lanugos are fading, right? But lots of Vernex. Okay. All right. So this is our recap. So now you know we want the baby head down, okay? And we're going to talk about that when we do complications. So by your 3rd trimester, an awake, healthy baby needs to move. That's an NCLEX question, okay? They need to move at least 3 times per hour. So what do you teach the woman if that is not happening? So if the baby is not moving, you have to tell her, eat something, drink something, walk. The baby must move, okay, at least 3 times every hour. If not, you need to be in the urgent care, go to the ER. Yes, the baby must move, okay? True story, many years ago, I have a cousin. My mother has a bunch of sisters and 1 brother. So her brother's first daughter was pregnant. This would have been his first grandchild. And she didn't feel the baby move, so she just waited for her next appointment. And, you know, unfortunately, the baby had passed away in utero. So she was way too late. So the baby doesn't move. I used to poke mine, literally, from the top when they're here listening to me. And I used to poke them when they don't move. Literally, I would poke them. I'm like, why aren't you moving? And then they would move. I'm like, okay, I go about my business. But yeah, I used to see their little footprints and stuff moving. They're supposed to move, okay? So NCLEX question. They don't move, eat something, drink something, walk. The baby has to move, okay? Or be in the urgent care, okay? So yeah, very, very, very sad. You don't feel the baby move, urgent care, okay? Now, there's false contractions versus true contraction, and you know the terminology, Braxton Hicks, I mentioned earlier. So let's do the false ones first, and then we'll talk about true contraction, and then we'll go into the phases of delivery. So false, Braxton Hicks. So with your false contractions, the Braxton Hicks, now these pain or contractions, they're not regular. They are irregular. They don't intensify. They keep the same volume, okay? The woman can walk, eat, you know, change positions. Their water has not broken. They're not effacing and dilating, no cervical changes. They eat, it goes away. They change position, it goes away. They breathe, it goes away. That's false contractions, okay? Now, true contractions are opposite of everything I've just said. Okay, true contractions will come regularly. You can set your watch to them. The frequency increases, the intensity increases, the mucus plug comes out, your membrane ruptures, your water breaks, you're effacing, you're dilating. That's true contractions. Okay, they start in the lower back and they move to the front. Okay, with Braxton Hicks, they're only felt in the front of the stomach or the pelvic region. They don't start from the back and like radiate to the front like true contractions do. Okay, so that's the difference between the two. Okay, so here's a picture of effacing. You see how the inner os, the outer os are gonna thin, thin, thin. And then dilation, the cervix is going to widen, 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 widen until we're 10 centimeters dilated. Okay, so that's effacement and then dilation. Okay, that's happening with true contractions. Now, there are some things you need to teach the woman during each trimester. Okay, so trimester number one, any trimester, any vaginal bleeding, any abdominal cramping, severe. We never like words like that, right? Severe and prolonged. Yeah, no, unless it's with good stuff, right? But severe prolonged vomiting, no. Persistent elevated temperature, no. Exposure to infection, including childhood diseases like measles, mumps, rubella, chickenpox, no. Okay, so you need to be seeing your primary or in the urgent care, the ER, with these signs. Now you're in your second trimester, all this that I've just mentioned, plus an increased pulse, urgent care, right? Fever, swelling of the face and fingers, headache, your blood pressure is most likely high, eclampsia, preeclampsia, right? A UTI, burning and urination, sudden weight gain. We want you to gain weight, but not 4 pounds a week. That's too much. Third trimester, all of that plus something we call anasarca. That means she is swollen everywhere. Not normal. Okay? So all of these signs, you need to be in the urgent care or in the ER. Something is wrong. Okay? All right. Now, fetal relationship. How is the baby in utero? There's several questions in this area. There's even hot spot questions in this area. So those visual learners wake up with, well, everybody wake up, because whether you're a visual learner or not, these are hot spots, right? So you need to see them. So fetal relationship. How is the fetal in utero? Where is the head? Where's the butt? Where do you put your stethoscope to hear the child's heartbeat? Okay, how is the fetal lie with the fetal attitude, fetal presentation? What am I seeing in that pelvic? Okay, so now I'm gonna come back, I promise. Here, so with these type of questions, you'll see words like LOA, ROA, LOP, RP. What are these words, right? So left occiput anterior is LOA. Right occiput interior is ROA. Left occiput posterior is LOP. Right occiput posterior is ROP. So now the L, the left, or the R, the right, is always the mother's left or the mother's right. A, interior, P, posterior, is always the mother's interior or the mother's posterior. The O in all of them is always the occiput of the baby, the back of the baby's head, okay, in utero. So let's do LOA, for example. Left occiput interior. Fetal occiput is on the left side of the mother's pelvic facing front. So let's see what that looks like, okay? So here's LOA on the bottom right here. This is the mother's pelvic. This woman is looking at you, okay? And you see the back of the baby's head, the occiput is facing front. So left pelvic, baby's occiput facing front. That's LOA. Now the hotspot questions say, where do you put your stethoscope to hear this baby's heartbeat? So here's LOA right here. So you would put, there's an imaginary box right there. There's an imaginary box right there. Okay? So that is where you would put your stethoscope to hear the baby's heartbeat if the baby is LOA. Now, if the baby's ROA, just go to the right side. Same thing, but on the right side. Now, when the baby's head, the occiput is facing posterior, the back, it is a little bit further to the side and a little bit higher. As you can see in this picture, LOP is a little and to the side. There's an imaginary box here where you would put that X. Now, NCSPN says that this box with your hot spots, the box is large and you don't have to be 100% inside the box, which is great. Okay, that's what they say every time we go to these conferences. All right, so these are all pictures for you. Here's LOP that we just did. I'm sorry, LOA, and here's LOP, and here's ROA, right side, because she's looking at you, and here's ROP. Now, all of these four presenting positions are all normal. That's what we want. We want the head first, but sometimes we have breach. So all of these normal LOA, ROA, LOP, ROP are all normal presenting parts. All of these heart rates are going to be below the umbilicus. You see the woman's belly button? This is all below, right here. The belly button is right there, below, 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 below. So normal presentation of the baby is below, the heart rate is below the belly button. When you have breach of buttocks first, right, foot first, those are the sound, the heart rate of the child is always above the belly button, okay? Like you see on the left side, this is a normal presenting, this is the baby's head. So the heart rate is going to be below the belly button. Now, here's a butt first baby. You see how the heart rate is going to be above the belly button? Okay, so let's practice. Well, there's one more concept I want to point out, and then we'll practice some questions. So station is also important. This is the mother's pelvic. At the very bottom of the mother's pelvic is what we call ischiospine, okay? Now, once the baby's head gets to the ischiospine, we say that the baby's head has engaged. Why does that matter? Who cares? What's the big deal? Here's the big deal. Until the baby's head is engaged at the ischiospine, the very bottom of the woman's pelvic, at 0 station, the umbilical cord can come through before the baby. So whenever you see, we give you a scenario and you see -1, because anything inside is measured at a negative number. -1, -2, 3, 4, 5, those are all dangerous because the baby's head has not engaged. Because once the baby's head engaged, there is no more room for the umbilical cord to come before the child. And you know, an umbilical cord coming first is a medical emergency. So we want 0 or +1, +2, +3, +4, +5. That means that there is no room for the baby's head to come, for the cord to come out, because then that would be a medical emergency. So if the presenting part lies below the ischiospine, the station is reported as a positive number, +1, 2, 3, 4, or 5. The baby is engaged, okay? And we are not worried about the umbilical cord, okay? So engagement means that the baby's head is not floating freely anymore. It has inserted in that pelvis. With your multiparas or grand multis, engagement occurs weeks before they give birth. Okay, hence why the baby comes quicker. So here's a couple of examples. An 18-year-old woman comes to the physician's office for a routine prenatal checkup at 34 weeks gestation. Abdominal palpation reveals the fetal position at right occiput interior. So picture that, folks. ROP. Which of the following sites would the nurse expect to find the fetal heart tone? So ROP is a normal presenting. So get rid of anything that says above the belly button because you know it's going to be below. Now we're on the right side. So get rid of left. That alone gets me to the correct answer. But do you see how we haven't been using, our test-taking strategies like nursing process, Maslow's, because this area, these topics, require you to really know your information. Yeah, you need to know the material. Okay. B, yes, I see an S. All right. Which of these women in the labor and delivery unit would the nurse check first when the water breaks? For all of them within 2 minutes. So let me do the same thing I did with the other question here, because the only word here that should be highlighted is the word first, or bolded is the word first. Okay. Let me just clean it up a little bit. Okay. So this is a priority question. But you're assessing all of them, so that's not going to help. Which of these women would the nurse check first, right? So step one doesn't help you because they're all assessment. You can eliminate anything. And they're all physical needs. So Maslow's not going to help you here. So you need to know your information here, right? You need to know what we just went over. So there's one woman here who takes priority over every woman. Okay, I see the answers, but can you tell me why? Just put, in short, why is it B? It is B, but why? I just want to make sure. I'm going to go over it with you, of course, but tell me why you think it's B. You all are correct. Absolutely. I'm getting some private answers too. I don't know if you all, yes, the station. So somebody just said it. The -1, that's it. Everybody else needs to wait. That -1 needs to be assessed first because of the umbilical cord. That's it. Everybody else needs to wait. It doesn't matter how many percent effaced you are, how many babies you've had. Prolapse cord is priority with negative station. Okay, but do you see how you need to have learned this stuff before? Okay, so let me clean this up a little bit too. So you see this is a priority question, right? After the shift report in a labor and delivery unit, which of these clients would the nurse check first? They're all assessment, so that doesn't help. They're all physical needs, are they? Yep, they're all physical needs. So then you gotta go ABC. Yes, can you tell me why? Tell me why you chose your answer, because that's important. Now, if awesome, and I love that this is one time I can say I love that we're not face to face, because usually students will yell out this answer, and well, I guess you typing it in is also same thing, but I want everybody to make up their minds, because this is the thing. If you read this question and you don't see that no fetal heart tone, then you're not awake. And you can't continue. You can't practice questions, come to class half awake. You're wasting time, right? You can't read an answer and you see no fetal heart tone and not process that. If that is happening, I'm worried. Okay, I'm worried you're wasting time, and that's not good. I tell students, listen, if you're doing questions and you're falling asleep, go to sleep. Seriously, go take that nap, take a good nap, enjoy it, take your time, lay there extra long. And then when you wake up, right, you're awake, alert, oriented, then you study. It doesn't make sense to be halfway doing, because you need your brain to process this stuff, to connect it, to make it make sense, to understand the why. So if you do a question like that and you miss that no fetal heart tone, I'm worried. Okay, so wake up. All right. Now, pelvic shape, we're going to take a break soon. So pelvic shape does matter. Okay, the best pelvic shape is the gynecoid. The worst one is the indroid. All these three are bad. Polypitoid, petipaloid, indroid, intrapoid are bad. The worst one is indroid because it's the male pelvic shape. The best one is gynecoid. So gynecoid is on the top left. Why is that the best pelvic shape for birthing? Because it's all round, all over. Whereas if you look at the others, narrow, 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 okay, it doesn't help. Indroid is the male. It's beautiful. It's kind of shaped like a heart, but it doesn't help birthing. Okay, gynecoid is the best pelvic shape for birthing. The other pelvic shapes, the woman's going to be in labor for a long time. We may need to use the vacuum or forceps. They may even at the end need a C-section. Okay, it's so funny we didn't know our pelvic shapes matter, right? But they do. Okay, so breech presentations. Okay, we want a head. We don't want a butt, a knee, a back. We want a head. We don't want that. We don't want that. Whenever you have a breech presentation, priority is the umbilical cord. We need to know where that is at all times, right? Because we don't want it coming before the child comes, okay? And when somebody has a breech presentation, there may be a need for an external version, okay? I've had 2 external versions. The children were head down because they were induced. So when we went to give birth, they were sideways. So we end up, NKJV. Oh, where's my picture? Oh, I have a nice picture here. It might be in the complications, but NKJV, this must be under the guidance of an ultrasound. We'll go more over breech when we do complications. So you know you're memorizing. Let me see. Actually, I think this is fetal monitoring. There's a couple of really... All right, I need to be careful when I'm at the bottom there. Okay, I'm back. Perfect. Okay, so fetal monitoring. You know you need to memorize the baseline heart rate, 120 to 160. Below that, Brady. Above that, tachy. That stuff you already know, okay? So now you know when you stress the baby, the heart rate changes, whether it increases or decreases, but it's supposed to come back to baseline. It's supposed to come back between 120 and 160. So when it doesn't, you know there's some type of hypoxia, decreased oxygen in this baby, and we do need to intervene. Okay, so changes in fetal heart rate may be due to hypoxia. We need to notify the physician. Okay, there are some things we can do first, like turn her to her left, put oxygen on her, things like that, but we're going to notify the physician. But we know all of this is happening because we're monitoring. And there's external monitoring, there's internal monitoring. Now, you can't monitor internally until the water breaks. So we monitor via Doppler, external total manometers, internal manometers, but internal requires rupture of membrane and the client to be in the bed, right? So let me show you some pictures of those of you who are like, visual learners. This is external, fetal monitoring, external, right? Here's internal. So internal, we can do the fetal scalp, okay? Or we can do, we can do the intrauterine pressure catheter. So the intrauterine pressure catheter is going to monitor the mother's contraction, whereas the fetal scalp electrode is going to monitor the fetal heart rate. Okay, but we're doing both. But before we can do any of that, mucus plug needs to come out, rupture of membrane needs to happen, and you know you are always assessing the amniotic fluid. You never want to see meconium in the amniotic fluid, because meconium gets into the alveoli that we were talking about earlier and blocks the child's airway, where the alveoli can't open and close, you know, like it's supposed to. We don't care about the meconium because it's dirty, because it actually is not. It's actually sterile, but we don't want it getting in the lungs of this child. So once the water breaks, you're assessing the amniotic fluid. If you see meconium, this woman may need to have an emergency C-section, okay? So do assess that, okay? Picture of that, you can take a look at those later. We talked about the ultrasound, and you're memorizing your baseline. Now, when the child's heart rate decells, there's different components of that. It could be an early deceleration, which is just from the contraction. It could be a late deceleration, which means placental insufficiency. There's not enough oxygen getting to that baby. Or it could be a variable deceleration, where the cord is being compressed, where a part of the baby's on and off the cord, okay? So let's go over all three. So now, early decel mimics, they mirror each other. What are they? They are the woman's contraction in the fetal heart rate. They mirror each other. One goes down, one goes up, okay? So when you have an early deceleration, I'm going to show you the strips, the fetal heart rate goes down when the contractions go up. When the contractions end, the fetal heart rate goes back to the baseline, okay? Very common, not a big deal. The contractions are causing it. They are not signs of distress. But with late deceleration, they do not mirror each other. You will see when the contraction starts, the contractions end, but the baby's heart rate stays below baseline. That is because that is a stressed child. That is decreased oxygen going to that child. There's hypoxia, okay? Hypo, not enough. So we do need to intervene. We're going to talk about how we intervene for the late deceleration. Early deceleration, they mirror each other, the contractions in the fetal heart rate, and there is no intervention that is needed. Late deceleration do not mirror each other. The baby's heart rate is still below baseline, even though the contractions are over. That is a stressed baby. We do need to intervene, okay? So here's an example of early decel. Do you see how right here, the contractions are over and the child's heart rate goes back to normal? Beautiful. Another contraction here. It's over right here. The child's heart rate goes back to normal. That's what you'll see in all of these early. You see how they mirror each other. One goes down, one goes up. And they're like little mountains that mirror each other. That's what we mean by that, okay? They mirror each other. You look at all of these, they're mirroring each other. You see, contraction goes up, it's over. Baby's heart rate goes back to 150. Contraction, over right here. Baby's heart rate goes back to 150. Okay, so those are all early. Now let's look at a late decel. So you see this contraction right here? This contraction is over right here. Why is this baby's heart rate not back, you know, within normal range? Why is it in the 80s over here, 180s over here? That's terrible. This contraction there's no contraction happening over here. And this baby's heart rate is not within range. That's a problem. That's a late deceleration. Here's another one. This contraction is over right here. It's over, it's done. Why is this baby's heart rate not within normal range? Okay, so those are all late decels. Variable usually is a combination of the two, and that usually happens when some part of the child is on the cord. Now, let's talk about intervention for late decels. The first thing, the best thing, the initial thing, the priority thing to do with a late decel is to turn her to her left. Now, if I had time, I'd go into the whole pathophysiological process, but the reason we turn her to her left is because of anatomy. You want more oxygen to go to the baby. You want pressure off the vena cava. So that is why we turn her to her left and not her right. Because as we cover this, and when you were in school, you were asking why the left, not the right. Okay? We're going to put oxygen on. If she has Pitocin, oxytocin, we're going to stop it. We're going to notify the physician at that point. But all of this needs to be done before we call the physician. Okay? PNs, you're notifying the RN. You knew that. Variable. We talked about that is from pressure on the cord. So change her position. If she was left, put her right. If she was right, put her left. And if she's standing up, her water breaks, most likely you'll get variable. Put her, supine in the bed. And after a little while, if there's nothing wrong with the child, you will see early decels. Okay? So it's just a changing position with the variable. So let's practice questions to see if you get it. The nurse cares for a client in labor. The fetal heart rate is 150 to 160. Awesome. The nurse notes that in apex of contractions, that the fetal heart rate is 125 at the apex of the contractions, and returns to baseline at the completion of the contraction. Awesome. Which of the following actions should the nurse take first? There's nothing you need to do here, right? Continue to monitor. There's no need to turn her to her left or right, nothing, because the fetal heart rate changes at the apex of the contraction and they go back to baseline. Continue to monitor her. That's it. Okay, don't let these questions throw you off. Here's another one. The nurse notes that a term client in labor is having persistent late decels. Now that's bad, you know that. The nurse should notify the physician because this indicates which of the following. So they want to know that you know what causes late decels. Is it cord compression, impending delivery, fetal distress, or uteral placenta deficiency? Yes, it's the deficiency, folks. What's causing late decel? Uteral placental deficiency. There's not enough oxygen going to that baby. That's why. That's what's causing late decel, which will cause fetal distress. But the question, you see the stem? The nurse should notify the physician because this indicates which of the following. Late decel indicates uteral placental deficiency. Okay? Awesome. All right, now medication. There's not a lot of medications in this section, which is great. We love that. There are a lot of medication when we do hypertension, of course, right? The cardiac section. When we do psych, there's a lot of antipsychotic meds that you need to be aware of, antidepressants, but here, not a lot. So the uterine stimulants, we're talking oxytocin, Pitocin, ergonovine, methylergonovine. Those are the meds that we want to give to induce labor, right? So we're going to cause uterine contraction. Now, if we allow a woman to go into labor naturally, the posterior pituitary secretes Pitocin, oxytocin. Here we're talking a synthetic man-made form of it that causes these contractions, right? So oxytocin is the most popular one, so we're going to spend most of our time there. The others are by mouth, okay, as you can see, and they're given in multiple doses, not to exceed 5. But Pitocin, oxytocin is the one you get questioned on the most, okay? That's always intravenous, right? And because it's IV, it must be on a pump. That's your NCLEX question. You have to titrate it when it's given IV, right? It has to be controlled based on the contraction. So if they're strong, we're going to decrease it. If they're not coming strong or they're not strong, we're going to increase it. So we titrate oxytocin, Pitocin IV based on the woman's contraction. So based on the frequency and the strength of the uterine contraction, this is going to be increase or decrease, okay? We also use these to prevent uterine atony, which we'll talk about. We don't want atony. I like this little mnemonic. When you get a chance, check it out. So Pitocin should be hung with normal saline, okay? See, your cervix is starting to dilate. The baby's head is presenting, so we'll start the Pitocin, okay? We're going to monitor mom's blood pressure, pulse, the fetal heart rate, of course. We would stop the Pitocin once the contractions are lasting more than 90 seconds. That's a long time, folks. That's a minute and a half of feeling a contraction. And they're coming less than 2 minutes apart. Stop that Pitocin. Okay? And she's 10 centimeters dilated. Stop that Pitocin. There's no need to continue it at that point. Okay? So not everybody's a candidate for this, right? It's contraindicated if you have PIH, fetal in distress, right? You're just not a candidate for this. So some adverse effects, seizures, put them on seizure precaution, hypoxia, it could cause intrauterine hemorrhaging. So again, not everybody's a candidate. But priority, you must be monitoring the fetal heart rate. You must be monitoring mom's blood pressure and heart rate. You must be, and it must be on a pump. It must be titrated. It must be controlled. Okay, you don't just give this stuff. All right. The opposite now, tocolytics. So go back. Your uterine stimulants, the name tells you uterine stimulant, you're stimulating, right, are to induce labor. Your tocolytics are to relax the uterine. They're the opposite. You're going to use those for women who are going in preterm. We want the baby to stay in utero as long as possible, so we're going to decrease and relax that uterus muscle. So that's magnesium sulfate, terbutaline, ridodrin. Those are all great, but magnesium sulfate is where your questions come from. So similar to Pitocin, oxytocin, it must be on a pump. Okay, it must be titrated, right? We must control it. And not everybody's a candidate for this either, okay? So there are some contraindication, okay? If there's imminent birthing, you're not a candidate for this. We're too late. If the baby's in distress, you're not doing this. Hypotension, hyporeflexia, you're not a candidate for this, okay? Not everybody's a candidate for this. So of course, we're monitoring mom and baby. That kind of goes without saying. Now, you need the antidote for magnesium sulfate at the bedside. We're going to start getting into some documents online. So you want to take a look at the antidote sheet. Magnesium sulfate is on there. So for magnesium sulfate, you should have at the bedside a gram of calcium gluconate right there sitting there. Okay. And we always do a medication reconciliation in general anyway. Every client gets a medication reconciliation. So we don't give magnesium whenever they're on a calcium channel blocker. Okay. So we don't mix CC defined. So now another medication that we use in labor is the epidural. Okay, so whether it's regular epidural, it depends on the physician what they want to do. They could do the walking epidural, but either way, the woman, they're numb, right? They're going to be on bed rest. You're not getting up, not being able to feel from your breastplate down, right? From your xiphoid down. So depending on what the physician is using, we're going to monitor for some things, but mom's respiratory status is vital, okay? And your epidural has a window, right? The whole window thing. We talked about window with diagnostic tests. Your epidurals have a window. And the window of when to give it is when the woman is 4 centimeters dilated until 7 centimeters. So after 7 centimeters, you're too late. Epidurals have a window, 4 and 7 centimeters dilated. That's when you give it. Before too early, after you're too late. Okay. So nursing intervention, when a woman has an epidural, you're taking the vitals, the heart rate, blood pressure, all of that. Yes. You're also putting on a Foley catheter. Okay. So you're putting in a Foley catheter, tell her she's on bed rest, she's not walking anymore, you're done. You're taking her vitals and the fetal heart rate every 5 minutes for the next 30 minutes. One more time, kind of sounds like blood administration, right? So there are some nursing intervention that you're just not leaving that woman. And this is one of them, okay? Blood administration is another one. You're not leaving these women, okay? You're taking their vitals every 5 minutes for them, so like you're not leaving. The RNs are not leaving, right? PNs, you can continue to monitor after the woman is stable, okay? If she's stable, you're gonna take the vitals every 15 to 30 minutes, monitor for hypertension, dizziness, headache, decreased respiratory status, all of that, right? And we really care about the woman's maternal respiratory distress because of the morphine that is in the anesthesia. That's one of the common narcotics used. And you know, morphine causes respiratory distress. So we're monitoring mom's respiratory distress. Okay. So headaches, shivering, backaches, all of that. There's a couple of videos for you. Some other medications we're giving, and the best time to give them is between 4 and 7 centimeters dilated, just like the epidural. So whether you're giving Demerol, Stardol, Nubain, okay, give them between 4 and 7 centimeters dilated. Okay, put the side rails up. At this point, because it's a safety concern, you can put all 4 side rails up and it would not be considered a restraint. One more time. In this setting, right, post an epidural, putting up all 4 side rails is not a restraint. Now, if you're in the psych unit and you're trying to prevent Mrs. Jones from getting out of bed and you put all 4 side rails up, yes, your intentions are different. So that is a restraint. But here, under this, it's not. Okay, she's on bed rest, left lateral. You know why. We want as much oxygen going to that baby as possible. Okay, so now there are a lot of maternal system adaptation to this baby coming out, right? To this pregnancy. So reproductive, there's going to be effacement and dilation. I showed you earlier. Cardiovascular wise, as the labor progresses, this baby's coming, her blood pressure is going to rise. So can you imagine if she was already hypertensive? So this is going to raise her blood pressure, right? Her anxiety, pain raises your blood pressure and your respiration and heart rate. Okay, so all of these systems are going to be affected. I want to spend a moment right here. So the mother's consuming more oxygen. Yes, pain, anxiety causes hyperventilation. So they're gonna be doing, right, that whole mess. You know that. So they're at risk of being respiratory alkalosis. Why? Because they're throwing out CO2. So give them that brown paper bag so they can breathe that CO2 back. Okay? They're at risk of hypoxia and hypocapnia can occur. Okay? So don't forget that. So during labor, they're at risk of respiratory alkalosis because they're blowing off CO2, which is acidic. They're using acid, so they're left with base. Give them the brown paper bag so they breathe it out. They breathe it back in. Okay. Renal is changing. You know that one's changing. Gastrointestinal decreased peristalsis and absorption. Okay. Stomach is slower to empty. They have decreased motility. Okay. They may have nausea and vomiting. Of course, they're tired, backache. You kind of knew all of that. But those are all the systems that are being impacted. So now let's get this baby out. So there's stages. There's first stage, second stage, third stage, fourth stage. So listen up, everybody. First stage is when the dilation and effacement is happening. I'm going to go through the phases in the first stage. There's latent, active, transient. Now, that is from your first true contraction until the woman is 10 centimeters dilated. So one more time, your first stage is from your first contraction to 10 centimeters dilated. Okay. Stage 2 is from 10 centimeters dilated until the baby comes out. Stage 3 is from the birth of the baby until the placenta comes out. Stage 4 is mom's recovery stage. Okay. All right. So go back. Under stage 1, you have latent, which is early phase, active, and then transient. Now, how do you know what stage and phase you're in? So if you're in first stage where the baby's still in, true contraction to complete dilation, when you're under phase or early phase, latent phase, phase 1, the woman is 0 to 3 centimeters dilated. Active phase, she's 4 to 7. Transient, she's 8 to 10. Okay? Now, you also need to remember the length of time these phases are lasting, right? And how frequently the contractions are coming and how long they are lasting, okay? So first stage, latent, lasts about 8 hours. If it's your first baby, okay, that's a long time. 8 hours, because it's your first baby. You're not gonna boom, 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 go through these phases and this is over with. It's your first time your body's going through this. There's some confusion. What do I do? But if you're a multi, 4 to 5 hours. See how it cuts it in half? Because you've been there, done that, right? Active lasts about 4 hours. Multi is 2. Cut in half. The transition phase, 10 to 15 minutes. Okay, whether you're preemie pair or multi-pair. Now here's all three next to each other: latent, active, transient. So you know how many centimeters each of them are. Latent, 0 to 3, active, 4 to 7, transient, 8 to 10, right? You also need to know how frequently the contractions are coming under each phase and how long they're lasting under each phase, okay? So latent early phase, they're coming every 15 to 20 minutes. They're lasting 30 to 45 seconds. That's not bad. You're at the beginning, 20 minutes. You can do a lot in 20 minutes, okay? Active, they're coming every 3 to 5 minutes. Okay, you only have time to yell at the other children briefly and then get back to ready for your next contractions. 3 to 5 minutes, not bad. But they're lasting 45 to 60 seconds. Okay, they're lasting longer. Now, your third phase, the transient or transitional, you don't have much time. They're coming every 2 to 3 minutes. They're lasting 60 to 90 seconds. Okay, yeah, so it intensifies, right? And they're coming sooner, lasting longer as the phases continue, okay? Here's a typical question. A client is admitted to the labor unit with contractions 2 to 3 minutes apart and lasting 60 to 90 seconds. Right there, you should know what phase you're in. Just from the contractions time and frequency, you should know what phase you're in. And don't mix duration with frequency. Frequency is how often they're coming. Duration is how long they're lasting. The client is apprehensive and vomiting. The nurse understands this information indicates that the client is most likely at what phase of labor. They are in transition phase of labor. Thank you. Absolutely. So that's how easy those can be, and they could be difficult if you don't remember some things. Now we're in second stage, okay? So now the woman is completely dilated, okay? Baby's coming out. That lasts about 30 to 50 minutes for the first timer, 20 minutes for the multi. So do you see how you need to pay attention? That's why I start with the way I teach this. You need to have known these vocabulary words. So if I tell you it's preemie, you know you have time to go to the cafeteria, and no, I'm kidding. But if it's a multi, you don't have time. I was teaching this class the other day, and I was reminded of my sister-in-law. This was, I think, baby number 4, where they didn't have time to get to the car. Yeah, my brother ended up delivering his own baby because she's a multi or grand multi. Okay, so they come sooner and quicker. So that's NCLEX. You don't have time. Keep that in mind. So let's go through the second stage of labor. There's what we call imminent signs. This baby's coming, and there's also what we call cardinal signs. There's these things that every baby does, right? So from complete dilation, 100% E-face and 10 centimeters dilated, there's gonna be a lot of bloody show. The woman's gonna feel the need, to bear down no pushing until 10 centimeters dilated, right? Don't miss that question. No pushing until you're 10 centimeters dilated, okay? Once you're 10 centimeters, then we can start to push. So there's going to be some crowning. Let's go over the cardinal signs. So the cardinal movement is one of those questions where you need to put it in the right order of how this child is coming. So remember earlier we talked about engagement, right? The baby's head hits the ischial spine. So once engagement happens, the baby does something we call flexion. So they descend, they drop, right? You hear that term, the baby drop. So flexion happens. They automatically, their chin touches their chest. That's flexion, okay? And they're still inside, right? So because they're still inside, they turn. So that's an internal rotation, okay? And then extension is when the head actually comes out and they do that, right? And then they turn again because now they're outside. That's called an external rotation. And you need to hold their heads at that point because they're going to turn, right? That's an NCLEX question as well. Hold their heads because they turn. And then when the rest of the body comes out, that's the expulsion. Now, stay tuned. Don't leave me early because I just have a couple of videos for you at the end. They're like a minute, 2 minutes long type of videos so you could get the visual and see. And you should be fine with any OB questions after that, okay? But this is one of those put in the right order, okay? So, oh, this is the external version. So we're talking about the baby coming out. I wanted to cover that before we actually have the baby come out in case you have a breech baby. So if you have a breech baby, there may be a need for an external version. I told you I've had two, I think the last two. So they were head down last doctor's visit, but then when we went to get induced, they were sideways. So my options are either C-section and an external version or go home and wait for the baby to be head down. I'm like, okay, no, external version. Nobody has time for the others. So NCLEX, this must be done under the guidance of an ultrasound. Because why, right? Why? Because the cord, you don't want the cord wrapping around the baby's neck. Now, there are a few sections on NCLEX, both RN and PNs, you get questioned on them like you do them, but you don't do them. You just need to know the process, right? So the physician would do this. One more time. The physician would do this, but you get questioned like you do it. I'm just the messenger, so don't shoot the messenger, okay? Another area that just pops through my mind is with arterial blood gases. We get questioned and having to know the Allen's test when we don't even do arterial blood gases. But again, I'm just the messenger. So when we get to that portion, I'll teach it to you, but I'm going to remind you, you don't do it. And this is another one. You don't do it. But you get questioned on it like you do it, so you have to learn it, right? All right. So after the baby's breech, your physician feels the head and rub the baby externally, turning the baby by applying pressure externally. That is an external version. So one hand is going to be here, one hand is going to be there, and literally clockwise. They're going to turn the baby, right? Here it is. But here, NCLEX right here. That ultrasound needs to be happening because if the cord is going to wrap around the baby's head, now we have a medical emergency, you need to have a C-section, okay? That's the only question from there. All right, so now baby comes out, the placenta needs to come out, okay? So third stage, placenta separation and expulsion lasts about 5 to 30 minutes. So it gets round and globular and goes back up, okay? That's just what happens with every woman. The uterus rises into the abdomen. Okay, uterus gets very round in shape and firm and it just goes up. And then the umbilical cord comes down, more blood. You can see that's a lot of blood loss. I've said that several times. Couple of things you need to remember here with the placenta. Don't forget, right? The umbilical cord has one vein and two arteries right here. Two arteries where waste is removed away, delivered from the baby, and the vein is where they get their oxygen and the nutrients, okay? So two arteries and one vein. Two arteries, one vein. And the arteries is how they get rid of waste. The vein is how they pick up oxygen, okay? The nurse cares for client in active labor. The client requests an epidural. The nurse anticipates an order for 1,000 cc fluid bolus with which of the following fluids? So this is a question testing to see that you know what's the best fluid, you know, to have up for the client in active labor who have had an epidural. Okay, so with these type of questions, you want to make sure that you're replacing lost electrolytes, okay, and you're not giving any extra dextrose. It's important to know that. So the dextrose, the 5% dextrose, and 1 and 2, get rid of it. Normal saline wouldn't add any extra needed electrolytes. So it would be the lactated ringers. Okay, lactated ringers replaces electrolytes lost during labor and adds volume to expand the vascular bed to reduce hypotension. So it's gonna do the job of the normal saline plus the electrolytes. And we don't wanna give dextrose, okay? The glucose is gonna be transferred to the baby. Great question, right? Great high critical thinking question. So awesome, and now you know why we would give lactated ringers versus D5W versus normal saline. Okay, awesome question. Now, 4th stage, mom's recovery phase, right? So mom is recovering now. Priority postpartum is hemorrhaging. We don't want her bleeding out, right? Hemorrhaging. So because she's already lost so much blood, whether it was C-section or vaginal, she's lost a lot of blood. Okay, so we want to make sure she's getting up with us for the first time because of orthostatic hypotension, right? And that stage could last quite some time depending on how traumatizing this was. So after hemorrhaging, our priority is to massage that uterus, because if you don't massage it and get it firm again, she's gonna bleed and bleed and bleed and bleed and bleed. And you know our priority was hemorrhaging. So it all goes together, right? All goes together. So we're gonna take some vitals. We're gonna massage that fundus. Boggy's bad. We don't want a boggy fundus. Boggy's bad. Boggy's bad. We don't want a boggy fundus. Okay. Ice to the peritoneum, not heat. We're gonna do sitz bath later. The first 24 hours is ice. Break that ice, put it in that perineal area, put it in that underwear. Okay, we want them to void within 1 hour postpartum. Within 1 hour, I want to see some urine. And then every 2 to 3 hours after that, I want to see some urine. Okay, within 1 hour, she needs to urinate. And then every 2 to 3 hours. So let's recap. Postpartum, priorities, hemorrhaging. Your next priority is to massage the fundus. We don't want a boggy fundus. Boggy is bad. And we're going to encourage ice to the peritoneum, not heat. Sitz bath will come later after 24 hours. She needs to void within 1 hour and then every 2 to 3 hours after that. Why do I need to keep her voiding regularly? Because if you keep the bladder full, the fundus is going to remain boggy and it's going to deviate to the side. So that NCLEX question where you go to assess her and her fundus is deviated to the side, empty the bladder. That's why. I have a nice picture of that coming up. Okay. All right. So we're going to examine the fundus. It's going to go down 1 to 2 centimeters every day. Okay. Now, ladies, men, you won't know this, but ladies, if you've had children, you know that that is not true over here, but you're going to go by the book, right? I teach by the book. I've had 4 kids. This is so not true right here. Okay, but we're going to go by the book. And I know it's not true because I ask students and women and stuff when I teach this class. Nobody has experienced that 1 to 2 centimeters up to 10 days, you're back to your pre-pregnancy state. That is such a lie. No, that mess doesn't happen that way, but we're going to go by the book. This is so comical. I'm like, what? So the book says, every day as you massage, the fundus is going to go and shrink and shrink and shrink 1 to 2 centimeters every day until day 10. And, you know, they swear you're going to be back to before you got pregnant. I'm like, what? Madness. That is so not true. Oh, okay, but we got to go by the book. We're going to observe the lochia, okay? 1 to 3. This is another area that is such a lie. This is so not true, but we're going to go by the book. Day 1, 2, and 3, rubia, it's red. That's like 10 days or more in real life. Day 3, 4, 5, 6, 7, serosa, pink to brown. That's another lie. By day 10, you're back to your, like, you had a normal period date. That is so not true. They need to change that information from the book. But I checked recently, it's still saying the same thing in the most recent updates. Anyway, by the time I champion that one. All right, so some changes you need to look postpartum. We have a little mnemonic for you called Bubble here. So I have the whole acronym here for you, what you're assessing with the breast and your uterus and the bladder. Some of it you already know, with constipation and everything. I'm going to pull out some NCLEX stuff, okay? Let's talk about the episiotomy. That's an important one, okay? So with the episiotomy, so some women tear naturally and some, the physician does it, right? So either way, right, ice for the first 24 hours, then the heat, then the SIDS bath, pain medication. You need to teach her to sit properly. How do you do that? How do you teach a woman to sit properly post an episiotomy? You tell her to Kegel, then sit like a lady, right? Kegel, contract that pelvic muscle, then sit properly, okay? Because that has happened. You have stitches. You can't just flop yourself on the chair, right? And we teach Rita. We're looking for any redness, edema, ecchymosis, drainage, approximation. We don't want to see words like foul smelling. We don't want to see words like purulent. We don't want to see words like that because we know there's an infection. Okay, so Rita is a nice little mnemonic that we use with the episiotomy to assess it. Okay, so if the little mnemonics help you, use them. All right, so to teach them how to sit. That's the Kegel, the breast part. We're assessing the nipples. We're teaching them about breastfeeding unless they're HIV positive. Other than that, we do encourage breastfeeding unless they're HIV positive. We want to decrease engorgement. So the way you decrease engorgement is if the woman does not want to breastfeed, do not stimulate, right? So let's go over your list. Where's my list? Right here. If you don't want to breastfeed, avoid any breast stimulation, stay away. Ice, tight bra, do not pump, do not put the baby on. Okay, they may need hormonal suppressant like Parladel, bromocriptine, okay? But if they do want to breastfeed, yeah, by all means, put them on there. The more you put the baby, the more milk you're going to make, right? But we want breastfeeding because that breast milk, it's full of antibodies, right? So we give the baby that passive immunity until we vaccinate them, until they make their own immunity. But that breast milk only lasts, like, immunity-wise, for like 3 months, right? That's why we start vaccinate and everything, okay? Here's the pituitary. You see how it's with the posterior pituitary with the prolactin and everything. Oxytocin we talked about earlier. It's all in the brain, okay? So we nurse the baby. The more you nurse the baby, the more milk you're going to make. If you want to wean them off, increase the length of time. Tell the woman breastfeeding 300 calories. We say while she was pregnant, it was 300. When she's breastfeeding, it's 500. She needs to drink a lot of fluid and stay hydrated, okay? And we talked about that. So the medication, if they need to suppress the milk, like let's say they're engorged or they don't want to breastfeed or something, bromocriptine, Parladel. We'll talk about Parladel again when we do pituitary, when we do endocrine, okay? So it's going to decrease the prolactin level and they'll stop making milk, okay? So if they have a breast infection, which is mastitis, okay, never abruptly stop breastfeeding. Even with mastitis, they need to pump it out, get rid of it. If there's discharge and pain, they can't breastfeed, they have to pump it out. Never abruptly. If you abruptly stop breastfeeding, you will get engorged. You have to wean off, okay? And if they're on antibiotics, they can still breastfeed on antibiotic. It doesn't cross the breast ducts, okay? The antibiotic does not, okay? So a lot of postpartum assessment. You know the woman's not getting up without you. You know you're assessing the lochia. You're watching out for orthostatic hypotension because they've lost all of this blood, Okay, you're assessing the bladder. If it's full, they need to empty it, or else it's going to keep that fundus boggy, right? And boggy is bad. The other thing you're going to do also is weigh the peri pads, because we can't tell how much blood she's lost, right? So because we can't tell how much blood she's lost, we guesstimate by how much the pads weigh. So when you weigh the woman's peri pad and it weighs a pound, that tells us she's lost 500 mLs of blood. That's the only way we can tell. Okay, because we don't have a bucket underneath them collecting this blood. We look at the peri pad. So you're going to weigh that pad. Okay, and as the days go on, we want to see words like light, moderate, scant, meaning just the, you know, we don't want to hear words like you're saturating, excessive bleeding. Like, no, we don't want to see words like that, because you're losing too much blood, right? Excessive, saturated, yeah, no. But you want to memorize this, okay? 1 pound. If the peri pad weighs 1 pound, she's lost 500 mLs of blood, okay? We talked about the lochia. Here's a question. A postpartum client who delivered 3 hours ago says, I feel all wet underneath. Which of the following should be the initial action of the nurse? So initial, hold on. It went to my complications. Initial should be bolded. That tells you this is a priority question, okay? So knowing that this is a priority question, you need to, I hope you didn't see the answer. You need to think of the nursing process, okay? Assessment versus implementation. Determine when she last voided will be an assessment. So it's going to tell you time. Ask the client to rate her pain. That's an assessment. Perform perineal care. That's an implementation. Have the client roll over to assess. That's an assessment. Okay, so we can get rid of C because we haven't assessed. All you have is some subjective data. You know, she gave birth 3 hours ago, and she says you don't have any of your observation, right? Okay, so get rid of C because you can't just jump to doing something without assessing, right? So you between A, B, and D. Okay, the pain is psychosocial. Get rid of it. So I go to my next step, Maslow. You see how this is a perfect question where I use my test taking strategies. So I get rid of B, that's psychosocial. So I'm between A and D, determining when she last voided or assessing her lochia flow. I feel all wet underneath. It is best to assess the lochia flow. Yes, D. Those of you who are throwing those answers at me, absolutely. Okay. You can ask her, yeah, about the voiding, but that's not the initial thing you want to do. After delivering a 9-pound, 10-ounce baby, a client who is gravida 5, para 5, first of all, that's a multi, and that's a big baby. Priority nursing care for this client should be, highlight bold priority. Palpate the fundus because she's at risk of uterine atony. Yes, she is, because she's had a whole bunch of babies, and this is a big baby. Okay? And if you pick assessment, you're assessing her diet. That has nothing to do with the stem of this question. It's the fact that she's multi, grand multi, and large babies. This has nothing to do with her diet. She's not at risk of anemia. Nope. Range of motion, nothing to do with the problem. But she's at risk of bleeding out because her uterus was stretched, right? And she's a grand multi. Cardiovascular, blood loss. Vaginally, 400 to 500 cc's. C-section, 700 to 1,000. You need to keep that in mind. So they start off hypervolemia, and now they're at risk of hypovolemia because of all this blood loss. All right, so we did quite a bit so far. Oh, these are the vitals. By the way, the moment you see a temperature postpartum, we're talking postpartum, 100 or higher within the first 24 hours of birth, that's a dehydration. Okay, but within like temperature greater than 104, so same, 6 hours apart after 24 hours, 2 consecutive days, that's an infection. Okay, so within the first 24 hours, we're thinking dehydration. 2 consecutive days, infection. Okay, just a couple of questions there. All right, so that's the end of OB. There's a lot of questions at the end for you to practice, and you're going to practice them. Yes, yes, you're shaking your head. Yes, you are. And the sooner you do it, the better. All right, so now, if you have any questions, let me know, because I'm just gonna jump right into pregnancy complications. And a couple of them, we're gonna stop and, dissect some things. And some of them is just FYI, right? Common sense, nothing for me. And then there's not many questions on a lot of these. Like polyhydramnios, like there's not many questions on those. But eclampsia, preeclampsia, yeah. So some of it, they're extremely important. Gestational diabetes is another one, right? So we'll slow down in those areas, but the others, we're just gonna boom, boom, boom. Okay, so any questions about OB? So we talked about not wanting to get pregnant. We got pregnant. We went through all 9 months of pregnancy. We gave birth. We went over postpartum. So that's a lot, okay? All right, complications now. Okay, so now hyperemesis is normal, especially if you're within the first trimester. Common 1 in 3 pregnancies, not a big deal. It's the HCG hormones that are, just elevating. It peaks around week 10, 11, 12. Okay, stay hydrated, not too big of a deal. But hyperemesis gravidarum is a big deal. That's not just, a little nausea and vomiting. This is women who cannot keep anything down at all. So they have extreme persistent. We don't want words like that when they're followed by nausea and vomiting, right? So fluid and electrolyte will be our priority here for this woman. Same thing, the HCG is the one causing it, okay? So we're going to give IV fluid, and we're going to give normal saline or lactated Ringers, depending on what their Kim panel come back as. We're going to pull their electrolytes to see what electrolytes we need to put in there, right? We're going to give them the Zofran, okay? We want to make sure they're not becoming hypokalemic, tachycardic, all of that. Not a big deal other than hydrating and the electrolytes. That's really our priority concern. Some women get sent home with IV infusion. All right, constipation. You know how to treat constipation. We're not gonna spend time on that. Low back pain. If they are wearing the belt to get the pressure off of the sciatic nerve, tell them do not sleep with this belt. Other than that, that one's not a big deal. But the problem is too much pressure being put on this sciatic nerve, and that's what's causing all that pain, okay? So the belt lifts it off. We talked about bleeding first, second, and third trimester, okay? We want to see what's the cause of that bleeding. Is it placenta previa, abruptia? So you want to look into the cause of these bleeding, and we're going to talk about these conditions that could cause the bleeding, okay? Ectopic pregnancy. Remember, we want the pregnancy in the uterine wall. We don't want it in the fallopian tube. We don't want it in the low os. So with ectopic pregnancy, there are some risk factors. Okay, previous tubal surgeries. We talked about the IUD being a risk factor if you smoke. Even that death exposure. This is that old drug for contraceptive that women used to use back then that causes ectopic pregnancy. So a lot of risk factors. But an ectopic pregnancy cannot or will not go up until 9 months, right? So this is a pregnancy that needs to be aborted. The HCG is gonna go up and down. Like your home pregnancy test is going to be positive, negative, positive, negative. Like you're going to have a lot of up and down. Treatment, treatment. You have to abort the baby. So earlier we talked about you taking folic acid, right, to make nice, beautiful red blood cells and prevent neurotube defects. So now we want to say methotrexate, which is the antagonist, right, of or to folic acid. So that's the treatment. That's the medical treatment. The physician is going to give you methotrexate to abort this baby. So there's going to be a lot of bleeding. Now, priority post and ectopic pregnancy is to make sure every fragment of the child is removed. Because remember, it's dead tissue. You cannot leave dead tissue in your body. You're going to hemorrhage to death, right? So we don't want to do that. Last case scenario, there may be a removal of the fallopian tube. Now remember, if she wants future babies, that's not a good option, right? Makes sense. A little sad too. All right, so recap, please don't forget this drug, methotrexate. Okay, methotrexate is the antagonist to folic acid. All right. Now, spontaneous abortion. Earlier, we talked about elective versus spontaneous abortions. Now, priority, whether it's elective or spontaneous, it doesn't matter. That's all a preference, you know, emotional stuff. Don't get involved in that emotional part. That's not NCLEX stuff. But NCLEX, you need to make sure every part is removed, because you may have a partial abortion, an incomplete or a missed abortion, but it doesn't matter. Whichever one, priority is for every little piece to come out. If not, you risk having a septic abortion. That's an infection in the bloodstream, could kill you, right? So priority, whether it's a incomplete, a miss, every part needs to be removed. Okay, no part of the baby can be retained. Okay, no part of the placenta, no part of the membrane can be retained. It's like leaving a gauze, it's dead tissue. A lot of risk factors for abortions. You kind of know that. We talked about DNC and DNE. All of these conditions we're talking about, assess the emotional stuff, because there's a loss, right? They need to vent. They need to talk about it. You need to know who their support systems are, right? They may need to grieve, okay? All right, the next two conditions, I want you to put them next to each other, right? Because first of all, when you get questions about one, there's answers about the other. And I'm talking about placenta previa and placenta abruptia. So let's go over what they are and what's the three major difference between them. So placenta previa, remember we went over the inner os. You see why I teach the way I teach, so that makes sense. So now you know where the inner os is. I've said it so many times throughout the review. Like this is like I'm in my moment here. Like I could teach all day, do this all day, because I feel like, okay, I get students to get it, you know? So the inner os, look how the placenta is blocking the inner os. There's no way this baby's coming vaginally, okay? Visualize it. That's a C-section. Now, in real life, some physicians will let you try vaginally if it's a partial, but NCLEX world, C-section. So now, that is the problem with placenta previa. You're hiding the inner os, right? So these are the babies where the blood is bright red. The baby is not in distress, and this condition is not painful. So one more time. Previa, placenta previa, the placenta is hiding the inner os. The blood is bright red. The baby is not in distress, and it is not painful. Now, placenta abruptia is a separation. The placenta is separating from the inner uterine wall. Right here where you see it says blood, it's another picture, blood. That blood is dark red. Where's my dark? It's somewhere here. Yeah. And the baby, this is painful, right? Obviously separation. It's painful, and the baby is in distress. Depending on the degree of the separation will determine the degree of the distress, right? So one more time, placenta abruptia is a separation from the inner uterine wall. The baby is in distress. This is painful. And it's opposite for previa. Is everybody good with those two conditions? Yay. Throw me some yeses. Polyhydramnios, poly, the prefix poly means too much. Amniotic fluid. Okay, the normal, which you should memorize, amniotic fluid is 800 to 1,000. If there's twins, there should be more. Okay, and these babies are swimming in over 2,000 mLs of amniotic fluid. Okay, so that's definitely too much, right? A lot of risk factors. They don't go too much into that. You cannot do the Leopard's maneuver with this condition, obviously. How are you going to feel this baby? You can't. Okay. The opposite now, oligo, not enough. These cause these children to have small lungs, large kidneys, large bladders. So let's talk about treatment first. So let's go back. Poly, you have too much. The only way to treat this is to do an amniocentesis. They're going to pull it out. Okay? So that's the treatment for that. Now, oligo, not enough. You have to hydrate this woman so that they make amniotic fluid. Okay? But they don't question you too much on those. Now, preeclampsia. Yeah, it's a lot. I just saw your statement. Think about, well, every program is different, right? So if you did an accelerated program, it probably was like 1.5 years, 2 years. If you did a bachelor's program, maybe a little bit longer. Some programs are even less than 1.5 years, but imagine even adding your prerequisites, right? So that's a lot of information. It's supposed to be a lot. It just is. So I don't want to downplay that. It's supposed to be a lot because remember your mother baby class was like some schools. I've only been to one school where I know they had like this 1 month thing. Like every month you go to a different class, but most schools it's 12 weeks or 16 weeks, right? For one class. So imagine, and some of your classes were 3 hours, 4 hours, 6 hours, depending on the program, how they set the program. So imagine we're going over all the important components of a 12, 16-week semester in 4 to 8 hours. So when I put it that way, you get why it has to be a lot. So what we're doing now, you did in a semester. Okay, so yeah, it is heavy. It's supposed to be heavy. And if I were to teach this in the time that you did go through it in school, yeah, I would need 12 to 16 weeks, yeah, to do it. So hang in there, okay? Accelerated program. Oh, you didn't learn enough. No. The accelerated programs, yeah, you have to really like not have a full-time job. And have time to read your chapters before class and have time to reinforce this and study. Yeah, the accelerated programs, usually you're doing 2 major classes together plus clinical, right? And some of them have lab and simulation. So yeah, accelerated programs are very intense. And depending on your instructor, would determine how much you take in. But yeah, it's a lot. I'm sorry. Hang in there. We're almost done though with this stuff. Give me 1 sec. I have to go to this screen to make sure some of you are sending messages privately, but I can't see them. So give me a second to see the private messages. Hold on. All right, everyone. At the end, I'm going to take a moment to answer some of these private messages, I promise. Okay? There we go. All right, so preeclampsia. This is an important one. Eclampsia kills a lot of women, so this is taken seriously, okay? So preeclampsia definition is new onset of elevated blood pressure and protein after 20 weeks of pregnancy, okay, of gestation. So all of us have a different baseline with our blood pressure, right? So if we were to go around and take all of our blood pressures, we're gonna get all these different numbers, okay? However, once you go past a certain number, it doesn't matter what your baseline was, okay? You're considered to be preeclamptic. So let's go over what that is. Where are my numbers? There we are. I'm gonna go back, I promise. So it doesn't matter what your baseline was. Once your blood pressure is at 160 systolic and 110 diastolic, you're considered to be in severe preeclampsia. But generally, whatever your baseline is, once your systolic is 30 millimeters over and your diastolic is 15 millimeters over, you're considered to be preeclamptic, okay? So we do go by your baseline up until 160 over 110, right? After that, we don't care what your baseline was, which makes sense. All right, so with preeclampsia, second leading cause of maternal death in the United States, last I researched, leading cause of fetal complications. So the children with mothers whose blood pressures are high or who were preeclamptic or eclamptic end up with low birth weight, premature, and even stillbirth, right? They come out dead, which is really, really sad to have gone through all of that and not have your child. So this is a serious condition. And the maternal death is usually due to the cerebrovascular event, which we're going to talk about in prevent, right? We're going to try and lower that blood pressure to prevent that from happening. Renal or hepatic failure. The kidneys and the liver literally stop functioning. We're going to talk about that. And causes a condition called HELLP syndrome. We're going to talk about that. So priority is to lower that blood pressure because this is a domino effect from high blood pressure. Imagine your blood pressure at 160 over 110. That's a problem. After Daniel, I was preeclamptic and needed to be on magnesium and all this good stuff we're going to talk about. And before then, I never had any issues, but I did do quite a bit when I was pregnant with him. Thank God all of this happened after I gave birth to him and not, you know, during like delivery, everything was beautiful. Just like 2 weeks later, boom, everything kind of went not so well after that. But with the babies, they end up passing due to something we call hydrops fetalis. So they get this excess fluid buildup. And that ends up causing their fatality. Terrible. All right, so HELLP syndrome, let's break this one down. So HELLP stands for hemolysis, that's red blood cells breaking in half, hemolysis, elevated, liver enzyme, low platelet. Okay, so the name kind of tells you the liver enzymes get elevated, the platelet goes down, which is why they have the thrombocytopenia and they need the blood transfusion, right? So the liver rapidly fails with this high blood pressure, right? Liver enzymes increase, platelets decrease, thrombocytopenia. So they have the right upper quadrant pain because of the liver rupturing. Literally, it splits in half, okay? So they're going to need fresh plasma and platelets. The baby needs to come out, okay? We're going to talk about that. So you could see, imagine how the liver is. So you could see how they're gonna have that right upper quadrant pain, not left, everybody, right, okay? Where is that? Right, not left, don't miss that question. Only the tip of the liver falls underneath the left upper quadrant of the abdomen, like if you were to do a plus sign on your stomach, right? From your xiphoid down to your symphysis pubis. And across your belly button, if you do a plus sign, right? Only the tip of the liver sits in the left upper quadrant, but the majority of the liver sits on the right upper quadrant. So that's where they feel that pain, right? So right upper quadrant pain, not left. So you're gonna pull the AST and the ALT, they're gonna be elevated, okay? Extremely elevated. And their platelet is gonna go down with the thrombocytopenia. We talked about risk factors earlier, and I talked to you about what we mean by young and old. But in addition to the age, your type 1 diabetics, your gestational diabetics, your obese clients, stress causes this to come on. Okay, so a lot of risk factors. Okay, so diagnosis is going to be based from your baseline up until a certain number. So we go from, transient to severe. So we go from transient to preeclampsia to severe and into eclampsia. We're going to talk about the difference between them. So with transient, the blood pressure is high, but no protein in the urine. Okay, that's the big difference here. With preeclampsia, the blood pressure is high, plus these clients have protein in their urine. So that tells you that the kidneys is starting to fail, right? Okay, so severe blood pressure is at 160/110 or higher, and you do a 24-hour urine collection, you have 5 grams of protein. Your kidneys are definitely shutting down, right? Oligo, not enough. Cerebral visual disturbance, they're swollen everywhere. Right upper quadrant pain, you know why? The liver split open, thrombocytopenia, the platelets go down. It's like madness here, right? So pay attention to all of that. We're going to assess their vision, right? We're going to ask them about their headache. We're going to assess the upper abdominal pain they're having. Scotomata is that visual field disturbance. Deep tendon, like when you dangle their feet and you hit them with that hammer, right? Clonus, decreased level of consciousness. So we're going to assess the blood pressure. We're going to weigh them daily, all that good stuff, right? Because it's not real weight they're gaining. It's not like actual gaining weight. So priorities to lower that blood pressure. We need to lower that blood pressure. Okay, so you're going to see the alpha, the beta blockers come in. Aldomet, labetalol, your alols are going to be a part of this regimen. Furosemide, hydrochlorothiazide, your diuretics. All of this is to lower the blood pressure. In addition to the antihypertensives to lower this blood pressure, magnesium sulfate to prevent this seizure. We talked about magnesium sulfate is one of those special drugs with multiple purposes. We just talked about magnesium sulfate as a tocolytic, right, to decrease uterine contraction, to relax the uterine for those who are going into preterm labor. So here we are talking about magnesium sulfate again, but from a different angle with a different purpose, right? So here we're giving it to prevent seizures. And now this woman is on seizure precaution. If I had time, I would ask you, what are the 3 things you need to do to be on seizure precaution? I'm just going to tell you because of time. So you need to pat the side rails, right? Pat them. Now we have these fancy pads that we just put there. But in NCLEX, if you see pat the side rails, yeah. Oxygen and suctioning needs to be at the bedside. Okay, oxygen and suction needs to be at the bedside and patting the side rails, because once they start to seize, they're gonna have a concussion. If you don't pat the rails, they're gonna hit their head and everything, on there. So please do that. Suction equipment, oxygen. Okay. Our goal is to reduce the risk of that cerebrovascular accident, that stroke that's coming because of this high blood pressure. Do not stress this woman. Last thing you want to do. So no noise. Get the children out of there. Turn off the television. Put a sign in the hallway. Everybody shush. Right? All right. Left lateral. You know why. Okay. We want to take pressure off the vena cava and increase oxygen to this client. Okay. So the baby needs to come out. You kind of knew that. The baby needs to come out. Now, what's the difference between preeclampsia and eclampsia? If I had time again, I'd have you chime in with me, but we're kind of pressed for time a little bit now. So the difference between preeclampsia and eclampsia is the seizure. If the woman has the seizure, her diagnosis changes. Now, when we did the nursing process, I told you the physician diagnosis doesn't change. This is the exception to that. So once you have had a grand mal seizure from preeclampsia, you are now considered to be what we call eclamptic. Okay, so eclampsia is a severe complication of preeclampsia. So in both situations, there's the high blood pressure, there's the protein in the urine, there's the edema, there's the patellar reflex, but now with the seizure, you are eclamptic. Okay, that's the difference, the seizure. Treatment is the same. We're going to increase, our beta blockers. We're going to increase the magnesium. The baby needs to come out. Okay. That was a mouthful. I told you eclampsia, preeclampsia. You'll see like the areas where I need to slow down, I slow down. All right, there's a number of reasons a woman could go in preterm labor, some of what we just talked about, okay? So same thing with post-term, not a big deal. However, it's not cute. Folks need to deliver when it's time to deliver. These are not heavy section. This one I want to spend a moment on, gestational diabetes. So this one is important. So you're not a diabetic, you get pregnant, you become a diabetic, you give birth, you're no longer a diabetic. That's gestational diabetes. So this condition appears when you're pregnant in your second trimester, and it disappears after birth. So one of the first tests, one of the tests that every woman takes second trimester of pregnancy is what we call the GCT, glucose challenge test. Okay, second trimester, about week 24, you're given all this glucose to ingest. Okay, I love sweet stuff, so I personally love it. So then once you've ingested this sweet stuff, if your pancreas is working beautifully and there's no hormonal issues causing this, your pancreas not to function properly, your blood sugar is going to be less than 140. Now, normal range for your normal blood sugar is 70 to 110. Yes, but for this condition, for this diagnosis, 140 is your mark. One more time, repetition, recap. Your normal blood sugar that we want you to memorize is 70 to 110. Yes, but for gestational diabetes, after the GCT, we want your blood sugar to be less than 140. So if it's 139, you're fine, you're done. But if it's 141, 140 or 141, you are considered to be gestational diabetic. So now after the GCT, you're going to do a GTT. If your blood sugar is more than 140, you're going to need to do a GTT. Glucose tolerance test. Now that is a 3-hour test. Every hour for the next 3 hours, I'm going to see what your blood sugar is. And 2 out of the 3 better be less than 140. Okay, and the goal, if you fail this test, and 2 out of the 3 are above 140, you're gestational diabetes, we're going to treat you by teaching you how to control your sugar intake. And we're going to observe for glycosuria, ketonuria, polydipsia, polyphagia, like a diabetic, the polys, right? The 3 polys. And here's an always. Gestational diabetes is always or only treated with insulin. Where's my insulin picture? I have a beautiful picture of somebody injecting themselves. Let's see my update. So only, that's an only, right? Gestational diabetes is only treated with insulin. Why? Because your oral diabetic agents cross the placenta. Okay, so they're only gonna be treated with insulin. Okay. Now, these babies that are born of diabetic or gestational diabetes mothers are usually fat and chunky, which we call macro, not micro. Micro is small, macro. Macrosomia. They're big, they're fat. I'll give you a true story. I'm not a diabetic, but all of my children were born big and fat and chunky. My first one was 9 pounds, something ounces. My husband knows how many exactly, I don't know, but he was fat. So I went in the nursery to grab him, and I went towards the fattest baby I saw, because all I knew is that I had a big baby, and it wasn't him. I almost accidentally grabbed the wrong baby because he was chunky, but I'm not a gestational diabetes. But they're fat, they're chunky, and they're at risk of hypoglycemia. Now, there's a couple of NCLEX questions as to the pathophysiological process behind that. Why are they chunky and fat? Why are they at risk of hypoglycemia? So while they're in utero, all that excess sugar causes them to be chunky, right? Okay, hence why earlier we told you don't give D5W while they're pregnant with that epidural because of all that excess sugar, right? Causes the placenta. Now, why are they at risk of hypoglycemia? Now, this is, you kind of need to think of them a little bit like a junkie, right? So while they're in utero, they're getting all this excess sugar. And then now they're out, right? So they're out and you cut the placenta. So they don't have that fix anymore, right? They're not getting all of this excess sugar, but they're making insulin. So treatment, feed them, whether it be breast milk, formula, sugar water. All right. Once you feed them, you take care of that hypoglycemia that's coming, especially their blood sugar will be below 40. Very dangerous though. Okay. Anemia you're familiar with. So do know that there's different types of anemia. Here in pregnancy, we're talking about low HH hemoglobin and hematocrit. Okay. So we want to pull that hemoglobin for that client day one, right? And first trimester, if it's less than 11 and the hematocrit is less than 35, and you see second and third trimester slightly different. So we want them to be on that, excess iron, folic acid, B12, full vitamin, right? During pregnancy, that helps avoid that, okay? So, if we're giving iron, we want them to take it with vitamin C or orange juice and tell them they're gonna get constipated. So drink a lot of fluids they should be doing anyway, right? Tell them that their urine is gonna be black and tarry, right? Eat roughage, walk, all that good stuff. Prune juice, right? All right. We talked about cord prolapse when we talked about engagement of the baby's head, right? So cord prolapse is a medical emergency. Now, our job, if you look at this picture, our job is to prepare for that surgery, yes, but also lift the baby off of the cord. Because once you lift the baby off of the cord, oxygen goes to the baby. So a couple of things, you're going to knee chest them or Trendelenburg, right? Sometimes you get these questions, like I know Kaplan throws it at you like that. I believe UWorld does that as well, where the woman's standing up, her water breaks, and there's cord prolapse, and she's standing up, right? So the answer to that is still to get pressure off of the cord, but that's the one where you want to use the sterile, right, gauze to get pressure off. But your job is not to manipulate, try and put back the cord, no. Get pressure off. So use the sterile gauze to push the baby off of the cord, put her supine on her back, knee chest her, put her knees towards her chest, or Trendelenburg her. This is Trendelenburg, feet up. Okay. Couldn't find a pregnant Trendelenburg picture. So that's our job, right? Trendelenburg her, do not manipulate the cord, get pressure off the cord, prepare for a C-section, prepare to resuscitate the baby. Okay, that's our job. Give oxygen to mom and you give oxygen to baby, but priority, get pressure off the cord. Whether you're doing that through Trendelenburg, knee chest, the sterile gauze, get pressure off the cord because that's oxygen to the baby, okay? Priority. All right, these are not as common. Home sign. This is a nice picture of the home sign. So you're gonna dorsiflex. So remember, the woman's been on her back for how many hours, right? Especially if she's a preemie, right? So there's a risk of deep vein thrombus, right? So we assess for that. A lot of physicians, well, research is showing that this is not done as much anymore, but just in case it's in your NCLEX, you wanna be familiar with it. So you're gonna dorsiflex, right? Push her foot towards her head, right? And if there's pain, then that means there's a deep vein thrombus, right? So priority, she has to remain on bed rest because if you allow her to get up and walk, then it gets dislodged, okay, and travels, okay? Another condition postpartum from the trauma is something we call DIC, disseminated intravascular coagulation. So this is an abnormal clotting problem postpartum. Okay, so the body's going to form these clots in reaction to the birthing trauma that they just went through. So these small clots are traveling throughout the body, depleting the body of the clotting factor and platelets. So that also causes bleeding. So they have a clotting bleeding problem going on, which is very, very difficult to treat. Okay, imagine you bleeding and clotting at the same time. Okay, so that happens a lot when women, the baby passes away in utero and they don't know about it, right? Happens with eclampsia, retained placenta. That's why we tell you all the little fragments have to come out, because this also causes sepsis if it's due to that. Okay, see, and they end up with what we call purpura. This is purpura. They're bleeding and clotting. That's just, very dangerous. Okay. There's two types of modality for C-section. You're familiar, low transverse versus the classic. Here's the big difference. With low transverse, less bleeding, less risk for infection, you heal faster, or also known as the bikini cut, right? You've heard of that term. The classic is the old-fashioned, more risk for infection, more bleeding, and a large scar. Right? So low transverse is preferred, right? Who wouldn't choose less risk of infection, less bleeding, healing faster, minimal scar, right? It all sounds so much better than that classic old madness we used to do. There's a number of reasons why somebody may need a C-section, and we've kind of, we talked about all of them. All right. Postpartum hemorrhage, we also talked about orthostatic hypotension. They're going to lose a lot more blood via C-section versus vaginal, okay, twice as much. So orthostatic hypotension. All right, priority postpartum. This is repetition. Postpartum depression, that's our last topic, versus psychosis. So a lot of women go through postpartum depression. I think the statistics is 1 in 3 or something like that, where it's a non-psychotic depressant period, where it's due to decrease in hormonal. Remember, you had all this high hormone and all of a sudden it's going to go down. So estrogen bottoms down, causes, the world is a mess. I'm so sad. Why did I bring a baby into that kind of stuff? So a couple of questions that the physician will ask, to differentiate where you are with this. Are you thinking of harming yourself? No. Are you thinking of harming the baby? No. And, that's really the big thing. It's going to wear off. You're going to get over it. So, but they might have some changes in appetite, decreased energy, some guilt. But again, ask those questions. You want to differentiate, make sure there's no suicidal ideation. But if there isn't, that's it. Now, if there is, that could be postpartum psychosis, right? So that you want to look more into, right? I know that was during her psychosis phase. Poor thing. So you see the turn that I was talking about, that internal and then the expulsion, the external rotation. So those of you who are visual learners, and when you get a chance, you can go ahead and take a look at the birth control one. I want to show you the episiotomy. That's a short one as well.
If you are having a vaginal delivery, your doctor may perform an episiotomy to enlarge the vaginal opening. During pregnancy, your baby grows inside your uterus or womb and is nourished by the placenta. When your baby is ready to be born, labor begins. During labor, your uterus squeezes or contracts to push your baby through the open cervix and into the vagina, which expands to allow your baby to pass through and be born. An episiotomy may be done in an effort to avoid spontaneous tearing during delivery if your baby is large or in the breech position, labor is going too quickly, or if instruments such as forceps or a vacuum extractor are needed to remove your baby from the birth canal. An episiotomy may be done to help speed up delivery if your labor is going too slowly, or if you or the baby are in distress. If you have not already received anesthesia before your delivery, your doctor will inject medication to numb your vaginal opening and perineum, which is the area separating the vagina and anus. Using surgical scissors, your doctor will make a 1 to 3 inch midline or mediolateral incision in the perineum. A midline incision extends straight down from the vagina toward the anus. A mediolateral incision is made on an angle from the vagina in the direction of the anus. The benefit of the mediolateral incision is that it is less likely to tear through to the anus. The downside, however, is that it can also be more painful and take longer to heal. Once your doctor delivers your baby and the placenta, he or she will close the episiotomy incision with stitches. These stitches will be absorbed by your body and do not need to be removed. An episiotomy usually heals without complications, although it may take several weeks. Within the first 24 hours, your nurse will likely help you apply ice packs to the stitches.
So you can see how there are a couple of NCLEX questions from there. And those of you who needed the visual, there's a couple more I want to show you. Here's station. This is a really good one with the station. That question in reference to the umbilical cord. That's the only thing I would add to that video, showing the umbilical cord, but don't forget that's a priority. And it would be a medical emergency, okay? There's a couple more I want to show you that are NCLEX questions. So we covered, let's do vasectomy, and then we'll do tubal ligation, okay?
A vasectomy procedure is a permanent method of birth control for men, where the surgeon cuts and seals off a section of the male reproductive tract in order to prevent sperm from exiting the man's body during ejaculation. A man's reproductive system includes the testes, two oval-shaped structures in which sperm, a man's reproductive cells, are produced. Leading from each testicle is the vas deferens, a tube that carries sperm to the urethra, a channel in the penis that transports urine and sperm. During ejaculation, each vas deferens propels sperm through the seminal vesicles and the prostate gland, structures that provide liquid nourishment and transport for the sperm. Now called semen, this combination of sperm and supporting fluids continues its journey through the urethra and is ejected out of the penis. During intercourse, the semen passes into a woman's reproductive system where the sperm can meet and fertilize an egg. If you don't want to impregnate a woman, you may choose a birth control method from one of several categories. Abstinence to completely avoid pregnancy by not having sexual intercourse, contraception to temporarily avoid pregnancy through use of various methods during sexual intercourse, or sterilization to permanently avoid pregnancy by having a medical procedure. Vasectomy is one form of sterilization. Before the procedure begins, you will be given injections of a local anesthetic to numb the area. In a conventional vasectomy, a scalpel will be used to make a small incision on one side of your scrotum, the thin skin pouch that houses the testicles. Your physician will locate the vas deferens and lift it through the incision. At this point, you may feel a pulling sensation. The vas deferens will be cut and a small piece may be removed. Next, the newly cut ends of the vas deferens will be tied, sealed with surgical clips or cauterized. The vas deferens will be returned to the scrotum and the incision closed with stitches. The same steps will be repeated on the other side of the scrotum. This procedure takes about 30 minutes. In the non-scalpel method, your doctor will use a special ringed instrument to hold and expose the vas deferens. From this point on, the procedure is the same as the conventional vasectomy. This method is usually associated with faster healing and fewer complications, and is just as effective as the conventional method. Immediately following either procedure, you will be asked to rest at the doctor's office for a short time. The incisions will heal in a few days, with little or no scarring. After your procedure, you will need to limit your physical activity for 1 to 2 days. You will not be able to shower for 24 hours. You will need to avoid lifting heavy objects, performing hard labor, and exercising strenuously for 5 to 7 days. You will need to avoid sexual activity for 7 days.
So that you can see for the female, and you'll see why this is a much complicated procedure as well. And I think there's one more. Let me just show you that.
A tubal ligation procedure is a permanent method of birth control, where the surgeon cuts or seals off the fallopian tubes in order to prevent pregnancy. A woman's reproductive system includes the vagina, the canal where sperm are deposited and babies emerge during delivery; uterus, the pear-shaped organ where a fertilized egg grows into a baby; fallopian tubes, two ducts that transport eggs from the ovaries to the uterus and where sperm usually fertilize eggs; and ovaries, two glands that produce and release eggs. During sexual intercourse, sperm from the male are introduced into the vagina. They travel through a channel called the cervix and into the uterus. The sperm then move into the fallopian tubes, where they can meet and fertilize eggs that have been released from the ovaries. Pregnancy begins with a fertilized egg. If you don't want to become pregnant, you may choose a birth control method from one of several categories: abstinence, contraception, or sterilization to permanently avoid pregnancy by having a medical procedure. Tubal ligation is one form of sterilization. Before the procedure begins, an intravenous line will be started, and you will be offered medication to help you relax. Local anesthesia will be applied to numb the area of the operation, and you will remain awake for its duration. In some cases, general or spinal anesthesia may be used instead. If you are having a laparoscopic tubal ligation, your doctor will begin by making a tiny incision near your belly button and another just above your pubic bone. Your doctor will then inject carbon dioxide, a harmless gas, through a tube inserted into the upper incision. The carbon dioxide inflates your abdominal cavity, allowing your doctor to clearly see and work around your internal organs. Next, your doctor will introduce a lighted instrument called a laparoscope through one of the incisions. The laparoscope projects images of the structures inside your abdomen onto a monitor. Through the other incision, your doctor will pass surgical instruments to grasp your fallopian tubes and close them off using the cutting and tying, blocking, or sealing technique. At the end of the procedure, your doctor will allow the carbon dioxide to escape and close the incisions with dissolving stitches. If you are having a mini laparotomy tubal ligation, your doctor will make a small incision just above your pubic bone. He or she will grasp the fallopian tubes with forceps and close them off using one of several techniques. At the end of the procedure, the incision will be closed with stitches. This method is often used just after childbirth. If you're having a laparotomy, your doctor will make a 2 to 5 inch incision in your lower abdomen. He or she will locate the fallopian tubes and close them off using one of several techniques. At the end of the procedure, the incision will be closed with stitches. Immediately afterward, you will be taken to the recovery area. If you have a laparoscopic tubal ligation, you will likely go home the same day. If you have a laparotomy or a mini laparotomy after childbirth, your hospital stay may be extended slightly.
Pay attention whenever you have a procedure laparoscopically and you're instilled with CO2, you need to be passing gas. That's extremely important. That's an NCLEX question, not just from a tubal ligation, but any procedure that is done, laparoscopically, that needs to happen. You need to be passing gas. Let's see. There's a vaginal birth, but that's not the one I wanted. I think you're good with those. Okay, yes, this is the one I was looking for.
Amniocentesis is a procedure that lets doctors detect or rule out problems with your baby's health long before birth. In the uterus, your baby is surrounded by amniotic fluid that provides protection and nourishment. Floating in the fluid are cells from your baby, providing doctors with genetic material for testing. In amniocentesis, your doctor will take a sample of this fluid to test for specific genetic disorders and birth defects. Amniocentesis is usually done in the second trimester of pregnancy at 15 to 18 weeks. It is generally offered to women with certain risk factors, age 35 or older, which increases the risk of chromosomal disorders such as Down syndrome, a previous child or pregnancy with a birth defect, blood test or ultrasound suggesting a birth defect such as Down syndrome or neural tube defects, or a family history of genetic disorders such as cystic fibrosis. Amniocentesis may also be done in the third trimester for these reasons: to determine if the baby's lungs are mature enough should early delivery become necessary, to diagnose a uterine infection, or to check for anemia in a baby with Rh incompatibility. To begin your procedure, your doctor would use ultrasound to create an image of the fetus and nearby structures on a computer screen. Looking at this image, the doctor can choose a safe place to insert the needle. Your doctor may give you an injection of local anesthesia to numb the surface of your abdomen, where the amniocentesis needle is to be inserted. Carefully watching the ultrasound monitor to avoid contact with the placenta or the baby. Your doctor will introduce the thin needle through your abdominal wall into your uterus and into the amniotic sac. He or she will then withdraw a small sample of amniotic fluid, remove the needle, and cover the site with a bandage. Your body will make additional fluid to replace what was removed. Your doctor will continue to monitor the ultrasound to check that the fetal heartbeat is normal and the baby tolerated the procedure well. You may feel mild cramping or pressure in your lower abdomen. For about 24 hours after your procedure, you will be advised to avoid physical stress, such as vigorous exercise, lifting, prolonged standing, and sexual activity.
Now, can you imagine that doing that under the guidance of an ultrasound? So you can see why that's a test question and why that's important. There's another one. We did that. I'm using pieces. Where's the other one? And you see, I like to just leave all of this at the end. That way we just do boom, boom, boom. Instead of stopping to play them all at once. Oh, I think I passed it because yeah, I'm past the pregnancy stuff. Okay, I'm using pieces. Okay, here's the cervical cap. This one will highlight quite a few things we did at the very beginning.
A woman's reproductive system includes the vagina, cervix, uterus, fallopian tubes, and ovaries. During vaginal sex between a man and a woman, semen passes out of the man's penis into the woman's vagina in a process called ejaculation. Semen contains tens of millions of sperm. From the vagina, sperm can pass through the cervix, uterus, and fallopian tubes to fertilize an egg from the woman's body. Fertilization of the egg marks the beginning of human development. A cervical cap is a form of birth control or contraception. It's a temporary and reusable device women can use to prevent pregnancy. Made of a flexible rubber, the cervical cap is shaped like a sailor's hat. It has a dome with a removal strap on top of it. The brim surrounding the dome has a short side and a long side. A cervical cap should be used with a substance that kills sperm, called spermicide, to increase its effectiveness. A woman puts the cervical cap in her vagina before having sex to prevent pregnancy. The dome of the cervical cap covers the cervix, which prevents the sperm in the man's semen from entering the uterus. The spermicide applied to the cap kills the sperm that come into contact with it. There are a few things to remember before using a cervical cap. Do not use the cervical cap if you have given birth within 8 to 10 weeks or had a miscarriage or abortion within 6 weeks. It is easier to become pregnant using a cervical cap during these times because the cervix is larger. Do not use a cervical cap during the menstrual period because it can block normal drainage of blood from the uterus. If you have an infection or other health condition affecting your uterus, cervix, or vagina, or if the cap is torn or damaged. To use a cervical cap, wash your hands and remove it from its container. Apply 1/4 teaspoon of spermicide inside the dome, up to and including the brim. Apply an additional 1/2 teaspoon of spermicide in the groove between the outside of the dome and the brim. Next, choose a position for you to begin inserting the cap. You can lie down with your knees bent, squat with both feet on the floor, or stand with one foot on a chair. Insert your index and middle fingers all the way into your vagina to locate your cervix so that you'll know where to place the cervical cap. Next, squeeze the cervical cap with the dome facing away from your vagina. Then slide the cervical cap into your vagina with the long side of the brim entering first. Using 1 or 2 fingers, slide the cervical cap as far into your vagina as it will go. Check with your fingers to make sure the cervical cap touches and completely covers your cervix. You can leave the cervical cap in your vagina for up to 48 hours. Before removing the cervical cap, wait for 6 hours after the last time you had sex. To remove it, squat with both feet on the floor. Insert a finger into your vagina to find the strap covering the dome of the cervical cap. Gently push the dome with the tip of your finger to dimple it and break the suction attachment to your cervix. Then, hook your finger through the strap and pull down slowly and gently. After removing the cervical cap, wash it with soap and water and allow it to air dry. The cervical cap is most effective at preventing pregnancy in women who have never been pregnant or have never had a vaginal birth.
Okay.
Cervical caps are about 96% effective at preventing pregnancy.
The cervical cap is reusable, but don't forget the sponge is not, okay? So keep that in mind for questioning. I also wanted to, let me see how long this one is. If it's too long, I'm gonna have you do it on your own, but that was the last one.
I found, Baby Center as a really big resource for me, almost like a friend. It follows me.
In the weeks before birth, your body slows down production of the hormone progesterone while increasing production of other hormones, including prostaglandins, which soften the cervix, and oxytocin, which triggers the uterine muscles to contract. True labor contractions are rhythmic and painful and grow consistently stronger. As the long vertical muscle bands of the uterus tighten, they pull the cervix open. The strong muscles at the top of the uterus push down and release, guiding your baby toward the cervix. The mucus plug, a collection of thickened cervical mucus that sealed your cervix shut for 9 months, may be expelled days before or in the midst of labor. When the amniotic sac ruptures, your water has broken. It can feel like a trickle or a gush of fluid. Your cervix will begin opening and thinning, known as dilation and effacement. Once you reach about 4 centimeters, your body will move into active labor. In active labor, contractions become stronger and closer together. At 8 centimeters, you enter what many consider the most painful part of labor, transition. By 10 centimeters, you're fully dilated and may feel the urge to push. This is your signal that the second stage of labor has begun. Your baby will move down with each contraction. The 3 separate soft bones of his head will temporarily overlap so he can pass through the snug birth canal. Your baby's scalp will come into view. When the widest part of his head is visible, your baby is crowning. With several more pushes, your baby's face, shoulders, and body will emerge. In the third and final stage of labor, your placenta detaches and is expelled. With your baby's first breath, the incredible journey of birth is complete.
Okay, so I believe, let's stop sharing. Oh, we've covered quite a bit, and the room is telling me that we're running out of time, so we must have started a little bit earlier. Any questions for me? So let me show you while I talk and you throw questions at me, what you're responsible for, okay? So we've covered a few client needs categories. Don't forget, under safe and effective care is management for RNs, coordinated for PNs, we've covered that. Safety and infection control we've covered, and we've entered health promotion, where we've done OB and OB complication. So we will be covering newborn growth and development, which is not heavy, but a lot again, because where the newborn, there are a few really important sections that you need to have under your breath. Like a lot of students have had the APGAR question, the losing heat questions with the newborns, growth and development. I know Eric Erickson is on your NCLEX. So those are some of the things we're going to talk about. Not heavy. After that, I'm going to knock psychiatric nursing, mental health out of the way, and then it's all about med-surg, right? And you know that's like so important, especially cardio. Cardio is a vital piece, and we still have quite a bit left. This is like the tip of the iceberg, because we still have introduction to pharmacology. We still have dosage and calculations. We still have, of course, all of the systems: cardio, respiratory, neuro, endocrine, GI, GU. And we also have basic care and reduction of risk, nutrition. So there's quite a bit left. Because again, we just talked about how long your nursing school was, and we know it was a lot, even if you did an accelerated program. Let me see some questions that I'm getting privately. Professor, where should I send Mary to you? Yes, email it to me, please. And then we'll have to set a one-on-one. You did, okay, I saw a question privately I think I answered the others. Okay, if you miss any sessions, I'll send them to you. I send them to everyone, and I try to send them as soon as possible. So probably like by tomorrow, you'll get this one, and you can look at it again and again. I think session 3 was having some issues. I sent it again. I see a hand up. Let me see if it's gonna work. I just did your thing, Philly. Let's see if it works. But don't worry, but I would advise you to do it as soon as possible. If you miss a session, get it done as soon as possible and start practicing questions on that area as soon as possible. Because remember, every time we meet is a new section, and I can't wait for you to get caught up. I have to move on and move on and move on, because it's a lot of information. You're kind of doing nursing school with me again, and that's okay. It's a lot of fun, but it is a lot of information. So please keep that in mind, and don't fall behind. Don't fall behind. And you have to keep practicing questions and stuff that we've already done. Okay? Any other questions? All right. Awesome. So email me, text me if you have any questions. I do have another class right after this. So if I'm not able to answer, I'll text you, but we'll connect. Have a great day, everyone. And I pray that you learned. I know it was a lot, but that's the way to do it. Have a good one.